Excellent, excellent, good. Sorry, thank you. Waiting for the sign. If I can start, welcome to this public board meeting of the Lancashire and South Cumbria Integrated Care Board. As always, I'd like to start by thanking members of the public who are observing this board, either in person, and we've got a few in the audience there, or through the live stream. I would also like to thank, I'm just looking to see if they're here, Lynn Almond, Derek Jones and Danny Houghton from Greenwich Leisure Limited at Kendal Leisure Centre, who are going to present the item, yes, I can now see you, on the community experience to board today, which we're very much looking forward to hearing in a minute. We'll just go through the preliminaries. I've had apologies from Sheena Comiskey, Denise Park, David Blacklock, Asim Patel, Debbie Herring and Dr. Sakthi Karunanithy. The meeting is, however, quorate. And as I always say, if we could, I'd like to maximise time for discussion. So I'd ask executives to keep the introduction of items brief so that we can do that. And the agenda and timings should allow for a good discussion, but there are some quite significant items on today's agenda. So, I haven't been informed of any conflicts or declarations relating to today's agenda. Is that correct? Yes, I'm not seeing any. That's excellent. And obviously, if there are any arise, as you suddenly think of them, just please do raise your hand. So, moving on to the minutes then of the last meeting, which was on the 22nd of January. Are we happy that they are an accurate record of the meeting? I'm seeing nods, great. And there are no current actions on the board action log. So we can move on from that if people are happy. Good. So we now move to the community experience, different by design, Kendal's Community Health and Wellbeing Hub. Jane, can I just hand over to you to introduce?
Thank you. Something that we learned about as part of the development of neighbourhood working and building on strengths that were already present in our neighbourhoods. There's been a long relationship between health commissioners, the Provider Trust, University Hospitals of Morecambe Bay and the leisure centres on the patch, particularly around physiotherapy and musculoskeletal services. And the service users describe a benefit to their whole life, not just in accessing health-funded services at the leisure centre, but getting involved in the life of the leisure centre and the life of the broader community. So it not only helped their pain, their musculoskeletal problems, but it helped their social cohesion, their sense of well-being, their sense of being a member of the community, and improved their well-being overall. So enough of me. I mean, there's a video, I think, and some real lived experience to share. Thank you, Chair.
Just put the mic on. Hi, Lynn Almond, Regional Health Intervention Manager for GLL. Just to give you a bit of background in terms of the project, we worked with University Hospital and Morecambe Bay Trust with funding from one public estate and local authority and the Health Trust as well. We created a joint approach in terms of shared holistic approach to prevention and rehabilitation. So we co-located the musculoskeletal service into our centres. Looking at other services, we compared co-location elsewhere, and it was very much about bolting on services onto leisure centres. What we wanted to create was a joint approach where we utilise staff in the right way and connected pathways as well, which I think we have very much created in the centre. We did quite a bit of pathway mapping in terms of how does that look in terms of just musculoskeletal, but other services as well. What can the leisure centre do to support the NHS, but also to support the local community? We've looked at a prevention focus primarily, but also rehabilitation. And it's very much about the power of the community and peer support. We found that peer support has been really crucial in terms of supporting people to help each other. And Danny will allude to a little bit about that in terms of the services that we provide. It's about supporting participants to make healthier lifestyle choices to prevent that representing to the NHS in terms of long-term health conditions, making those long-term improvements in health. And I think that's what we've managed to do in the co-located model. In terms of funding for the service, we've had very little investment in terms of pathways. What we've managed to do is look at self-sustaining models. So our exercise on referral model that we've delivered is a funded model by participants, but it's heavily subsidised. So that model is now self-sustainable. In equally escape pain, we did what we thought was right by putting the service on free of charge with the consideration that we'll potentially get funding. That funding hasn't arrived, so we've taken the decision to start to charge a small amount to participants. What I'm trying to say is that we don't necessarily need funding from the NHS or council partners to be able to deliver these services. I do believe that people are quite willing to invest in their own health. Obviously, there are pockets of deprivation where people do need that support, but I think we need to be smart in terms of where we're funding and how we're funding. And I think, again, with this model, we've managed to show that we can make the best use of the local pound. In terms of services that we're delivering then, I'll pass over to Danny, our Health and Communities Manager for Westmoreland and Furness, and she'll give you a bit of an overview in terms of the services we're offering.
Hi everyone, nice to meet you all. Just a quick whistle-stop tour of some of the services we offer within the Wellbeing Hub at Kendal and surrounding leisure centres. Firstly is the Healthwise programme, which is a 12-week exercise on referral scheme. Once participants complete the initial 12 weeks, they have access to a 2-year subsidised membership which supports that long-term behaviour change. Participants can also access cardiac, pulmonary, cancer rehab sessions and aquatics for health and other water-based sessions which are run by the Better Health team. In the 4 years I've been working here, the membership base has grown from 26 to I think 801 we're up to now, which really just shows demand for the service and the strong working relationships between leisure and primary care. It also demonstrates that we do have a strong focus on prevention over treatment, and this project as well acts as an exit route for various NHS physiotherapy and other group exercise classes. Moving on to Escape Pain, which was designed by Orthopaedic Research UK. It's a 6-week intervention that combines education and exercise to give participants sort of, like to describe it as a bit of a toolkit, so kind of different non-pharmacological ways to help them self-manage chronic hip, knee and back pain. In the 3 years we've been running this service, we've had I think around 640 participants enrol onto the programme. Completion rates are just over 60%. We've had lots of self-reported reductions in medication use, increases in function, ability, and as well we've had times where people have delayed or even removed the need for surgical intervention, which is absolutely fantastic and demonstrates just what can be done in such a short space of time. Once participants complete this, they also have access to the 2-year subsidised Healthwise programme to support that long-term behaviour change if they want to carry on using leisure facilities. It's estimated the net savings to NHS is about £505,000 and return on investment £8.80 for every £1 invested into that programme. Moving on to the Workwell scheme, we were lucky to be involved in the initial pilot in South Lakeland. It's essentially a back-to-work scheme for people with long-term conditions that's been rolled out nationwide. The local leisure centres are embedded within the social prescribing pathway for the work and health coaches, so they can refer participants into the Healthwise service and they receive the 12-week free of charge physical activity intervention. We've had around 18 referrals for this service year to date, and upon having those 12-week reviews with people who've managed to see the programme through, 4 of them are returning to full-time work, which is exactly what the programme's there to do. Moving on to Chatter Matters, now this is our, it was originally funded as a warm spot back in 2022. The group has now evolved to 5 self-sustainable older adult social groups. And Chatter really does matter. The groups have decided to call it that name for themselves, and it really just shows how it aligns with the aim of this project, which is to just support people in social isolation, especially in our ageing population within Cumbria. And it's also started to act as a bit of a social prescribing hub, so we get lots of organisations who come along to tell participants about their services and how they can be accessed. And last year we had around 4,000 visitors into that project on its own. Community projects, we're well aware, leisure centres cannot provide everything. People maybe don't want to access leisure or do not want to. So we're often signposting to local groups and clubs. These include the accessible cycling charity Wheels for All, Age UK and their various walking sports groups, wellbeing walks and the Breathe Easy groups through the local respiratory network. We are in the process of adapting a spare underutilised space at Kendal Leisure Centre to become an active wellbeing hub to really promote active travel, to give some of these groups a bit of a home and a bit of a base where they can store equipment and have that meeting space so they can support each other with those social interactions and social connections that they've already got. We also work closely with local integrated care communities to provide an annual health festival. So this gives young people the opportunity to engage in some free active play and try some new things they've maybe not had a chance to do before. And it gives carers, parents a bit of respite. They can go and get a health check and check out what local groups and clubs and wellbeing supports available to them. Moving on to the age-friendly South Lakeland project. This is much bigger than leisure. It includes housing, transport, outdoor spaces and buildings, employment, volunteering, you name it, it comes under the age-friendly banner. We've been commissioned by Cumbria Community Foundation to lead on the project, and it's really allowed leisure to work with a wide variety of different partners. Now all these partners have agreed actions which have been informed from a survey that was put out a couple of years ago. So this includes things like Age UK providing volunteers to go and age assess local businesses and shops to deem them age friendly, which are then reviewed on a mystery shopper basis annually. The local authorities putting together an information booklet of local funds and available support to help people stay independent and healthy and happy at home for as long as possible. It's working with Cumbria CVS to host a range of volunteering fairs to get people into local volunteering opportunities. And we've got the local dementia community working behind the scenes to deliver dementia friends sessions, so businesses, individuals can really make every contact count within their local communities as well. And we're really pleased to say that this piece of work is heavily informing how other areas of Westmoreland and Furness will become age friendly in the near future. And finally, our most recent project has been what we've deemed the Better Health MOT. So we've partnered with UCLan University, and the team have been trained and assessed by GPs to deliver NHS standard health checks out in the community. Since we launched it 12 months ago, we've had around 120 health checks completed, shown a huge success, and we've had lots of positive feedback around the like for the non-clinical setting, instant results, and the take-home information booklet, which people can then take along to their GP surgery should any high readings need following up. And it's also a very versatile project that can be taken into workplaces to support workplace health as well. I'll pass you back over to Lynn.
So, lots of things going on. In terms of outputs and outcomes, we do measure what we do. We collect data, pre and post activities. There's a huge amount of data we collect in terms of participation. We work with the UK Data Hub, which translates all of that data into social value. So for Westmoreland and Furness, we generated over 8.2 million in social value for last year, which was really, really good. And in Kendal in particular, that was around £2 million in terms of social value. So, but in terms of looking and working with you guys, I think we've got a really good opportunity, and I have had conversations around overlaying your data within, say primary care, with the data that we've got, looking at things like avoiding GP appointments or reductions in medication and, you know, things like that. So when we're looking at neighbourhood health, how do we work together to demonstrate the wider impacts of both primary care and community activity as well? So I think we've got a really exciting opportunity with neighbourhood health. We created a video a while ago, which we're going to play for you now. It is a little while since we did it, but it gives you a flavour of what the centre's like and a few of the participants that are taking part in the setting as well. I'll let you have a look at it now.
It's made me get involved in more things. You're very much included here.
They've built my confidence absolutely sky high.
The programme, I feel, is really tailored towards me.
They do remember you. It's not as if you're an individual that comes in and out.
We've got the MSK department running out the leisure centre, which is absolutely ideal. It saves people having to go to the hospital to get seen for their aches and pains because they can come and get it seen in the leisure centre, get a feel for the place, meet the staff.
We are the IMSK service, which stands for the Integrated Musculoskeletal Service. Patients get referred from GP practice and come and see us with any musculoskeletal problems. We are able to see them in the community setting, which is sometimes a lot more inviting for patients.
And then they're thinking about being a bit more active, and then they can be referred from the MSK team onto Escape Pain or onto the Healthwise programme to help manage their aches and pains and their medical conditions through being a bit more active. So I'm in our inclusive gym now, which is just another avenue of how Better Health can help people manage their medical condition through being a bit more active. People can be referred to us for both mental and physical health conditions through their healthcare professional, and we're just there to support them into being a bit more active to live happier and healthier lives.
With the Healthwise, you actually get a gym induction, which I really enjoyed.
My attitude to health and fitness has changed enormously. I just don't understand why I didn't do it before, really.
The benefits came quickly, within a week or two. Excellent service, really well run.
I think it's very good value for money, and the more classes you do, the better value for money it is.
It's a really good community feel. Everybody talks to each other.
As a group, we don't feel as self-conscious. It gives you the enthusiasm to carry on and do a bit more.
I was in a very dark place, and the team here have got me out of that and got me refocused on what I want.
Thank you. We've also created a bit of a handout which we gave to Minal on a recent visit, so we've brought along a few copies if you want to take a copy with you, and that's it from us.
Thank you. Thank you very much indeed. And this is not the first time I've come across your organisation. I was in the east of the patch as well. You're doing some really innovative things that are absolutely spot on where we're trying to go with neighbourhood health. So I found that particularly stimulating, and I know Aaron wants to come in as well.
That's all right. So Lynn, Danny, thank you very much. I think it's the second time we've met each other in recent times. So I have to declare an interest that I'm a patient of the IMSK service, and Kendal Leisure Centre is my gym. Thought I might have seen myself on a treadmill there. That was a heart in the mouth moment there to what me and my short. So there's a couple of reflections. So I was also at the Provider Collaborative Board recently, where colleagues from another GLL unit in the Leisure Centre were talking about the expansion of things like therapies and outpatient services. So just for the board's attention, both from our strategic commissioning perspective on neighbourhood development, but I know the providers are also looking now at things like the broader public service estate utilisation. This is a key piece of work, I think, for us. And one of the things you said, Lynn, about £8.80 return for every pound invested,
yeah.
We simply don't look at some of our VCSFE, some of our broader public sector and estates contributions in the same way. So for me, there's something for us as a board about how do we understand the value of the budgets that we have available to us and where we put it best in the market. Apologies for the commercials, but you'll understand what I mean by this. Is I just don't think we understand well enough yet where the best value for our investment really sits, and this is a great example of where I think people like our finance committee might be really surprised around the opportunities here. So we'll need to do something a bit better, I think, about how we report performance, how we understand value, and how we build our strategy going forward. But massive thank you for sharing this story again. I'm not sure if GLL have got the monopoly on us at the minute, but there's 3 or 4 meetings in the last month where it's featured quite a lot. But the value in the relationship's really clear to me. Thank you for sharing again today.
No problem, thank you.
Thank you, Aaron. Any other comments from board members? No. Sorry, Chris, yes.
Cheers, thank you. I was just thinking, so how do we get this across the whole of Lancashire and South Cumbria? I suppose there's a piece of I know so for discharging patients from some of our hospitals in Blackpool as mental health hospitals, we use Blackpool Leisure, and then it gives people real purpose when they then get discharged for that. But that doesn't happen necessarily across the whole of Lancashire and South Cumbria. So I don't know, is there something that we could do, I suppose, more at that strategic level around making sure that we get this consistent for populations across?
So Adrian Leather from Active Lancashire is working closely with Stephen Sanford, and we've got a Pivot to Wellbeing group, which is looking at how we get this model rolled out across Lancashire and South Cumbria, you know, so that we can support more people in the same way.
Yeah. I just think that whole thing about, I'm thinking talking therapies, and we could have that aligned with leisure centres, and then so much health and well-being with this. Thank you.
No, thank you. Silas.
Yeah, thank you. So Adrian Leather, who's just mentioned, actually presented at the Provider Collaborative last week, which is all of the provider NHS trusts working together. And what we're looking to do now is really focus on the MSK work that yourselves have been doing, with a view to scale that up across the patch, because you know, there's clearly the benefit to patients, but also our staff report back they prefer working in that environment. You know, they can park, they've got the equipment, they don't have the pressures that normally face on a busy hospital site. So it seems a real win-win for all concerned. So watch this space.
One thing I can just mention, when you're talking about staff, we've got 140 new NHS members from them being co-located into the centre. So it's about staff wellbeing as well, rather than just participants. So, yeah.
Good. Thank you. Tracy.
Yes, just a quick one from me. I think absolutely fantastic what you've described, and absolutely agree with Silas and Chris about how do we expand this, but I just want to kind of give the health inequalities lens to this and say that in some areas what you're doing wouldn't work unless we adapted it to meet the needs of that local population. But I'm particularly thinking about where there's a charge applied to some of this service. You know, my day job is in Blackpool, and I know how difficult it is for Blackpool Leisure to do this type of work and build in that model of sustainability around even small charges. People disengage fairly quickly if they think there's going to be a charge because they simply can't afford it in many communities. So I'm absolutely behind it. Please don't think I'm not. But I think we just need to consider what will work in each of the places and the communities that we're serving as across Lancashire, South Cumbria.
Yeah, 100%. And I think that's what I said, what I meant when I mentioned that we need to be really careful and tactical in terms of how we're spending funding. So potentially Kendal area, we're quite affluent, we don't potentially need that funding, whereas Blackpool most certainly does. So that model would need to be funded. So there's the framework of services, but how it's funded needs to be reflected in each area, doesn't it?
Thank you. Thanks, Tracy. Steve.
Yeah. Thank you, and thanks for the presentation. That was great. I visited the Blackpool Centre a couple of weeks ago, well, a month ago, where they're doing something very similar, and it would be great to see it extended across the whole patch. And just a bit of lived experience. A couple of decades ago, I had to have my hips resurfaced, and I was advised to get fit before the operation, which I thought was a bit counterintuitive. But I did. I spent 3 months in the gym, getting stronger and fitter, and my surgeon was adamant that had helped my recovery afterwards. So, and then I did the same thing again 2 years later on the other side. So patients should be aware that this is very beneficial to them.
There's almost an argument for anyone that's coming up for hip and knee surgery should potentially be put through escape pain, or offered escape pain, not put through it, that sounds a bit... But yeah, definitely offered escape pain as a bit of prehab rather than straight to operation.
Great. Okay. Thank you. Thank you very much indeed. You're more than welcome to stay and watch the rest of the board if you would like, but we do understand if you need to leave. So thank you, but thank you very much for coming. Excellent. Good. So the next item is my Chair's report, which as always I take as read, very happy to answer any questions. There are just a few words that I'd just say as a preamble to today's board. I mean, as I've said at this board, there are 3 really big areas of work that has been occupying us a lot of the time of the executive, but actually throughout the organisation over the past few months, and they are all reaching their culmination shortly. Firstly, we say goodbye to nearly 200 staff members of all grades across the organisation who've taken voluntary redundancy in response to the national scheme. And I want to take this opportunity, I did mention it last time as well, but I want to take this opportunity to thank all staff members for their patience and professionalism through what's undoubtedly been a very difficult time. And on behalf of the board, I'd like to give our very best wishes for those who are leaving us. And for those who are staying, we do appreciate that there are still uncertainties around the future model ICB and what that means for your roles. But it is our intention to address that uncertainty with clear structures very shortly so that we can organise ourselves in a way that will deliver on the vision that I know Aaron has set out throughout the organisation and beyond. The second thing is that we have successfully submitted our medium-term plan, our 3-year plan, yesterday, in fact. And this has been a massive effort across the system, and to make sure that all the plans are consistent and triangulated across performance and resources. This, together with our strategic intentions, will be discussed later on today's meeting. But it is a big piece of work that is the significant achievement. And thirdly, we do still remain on track to deliver our financial outturn for 25-26 when the year ends at the end of the month, both as an ICB and as a system. This is a huge achievement, Board members will remember me saying about 12 months ago that delivery is delivery, and if you can't deliver financial, you can't deliver quality, we can't deliver for the population we serve. So this is an important milestone for us as an ICB and for the system in demonstrating that we do understand what it takes to deliver, and I'd just again like to pay credit to Aaron, to his predecessor Sam, and to the executive team in particular for the effort and leadership that they have provided on this. Thank you. Very happy to take any questions on the paper itself, in which case we will pass on to Aaron.
Thank you, Chair. Never follow the Chair who's pinched half of my report, but that's okay, Chair. But I will reiterate, I think, some of the reflections the Chair's just given. I've only been in the organisation for 4 months now, but our colleagues, some 800 strong, have delivered improvements in care and quality and performance alongside financial improvement and a strategy that makes sense, I think, at the same time as real uncertainty and restructuring. Credit goes, yes, to the executive team, but there are hundreds of colleagues in our organisation who've always faced the right way and put communities and patients first as we've tried to deliver the improvements that we've taken on board. I do think we need to recognise how much more there still is to go. So huge inroads in a year, but lots of challenges both in terms of performance and quality improvements and access for our patients, and a financial challenge. But the start from the system this year has been nothing short of phenomenal and puts us in a really strong position for this next phase. There are a number of items in my report, but I'll just pull out a couple. So as part of the restructure and the changes to the ICB, I've appointed now to the executive team. So just to draw out the colleagues that are part of the team going forward. So delighted that Craig Harris continues in the Chief Commissioning Officer role, and following a due process, Mark Bakewell has been appointed as the Permanent Chief Financial Officer. I can see Alex in the crowd, so hi Alex. So Alex Heritage has been appointed as our Chief Strategy and Planning Officer and will join us on the 1st of June. Now, we weren't successful in our appointment to the Chief Clinical Officer, which we will revisit later on in the year, but I am delighted that both Jane Scattergood in the role of Interim Chief Nurse and Andy Knox in the role of the Acting Medical Director have agreed to continue in their respective roles over this period. We are also looking at a shared role for the Chief Medical Officer, so I'll be able to announce at the next board a colleague that will join Andy in sharing that role going forward. So just wanted to note those executive appointments, Chair. The only other 2 or 3 things I will pull out. So both Lynn and Danny referenced a visit to Kendal with Manal Bakai, who's the national lead for the neighbourhood development work, alongside Dr. Claire Fuller. I was delighted to be part of that visit with Steve Sanford, who's leading our neighbourhood health improvement work. it was a fantastic example of what happens when you give more autonomy and budget and some convening of partners in a place to focus on the right things, and a reminder that not everyone has to be in the purview, support or control of us as a board. I think our system partners now are showing real commitment to that system working at neighbourhood level, and that was just one example, so it was pleasing to see the national team see that in practice. And then 3 updates. Colleagues will be aware that we had committed to bringing an update on the GLP-1 weight loss management diabetic drug prescribing approach for the ICB into this board. We had prepared that work but had notification of a change in national policy in the prescribing of this drug literally the afternoon of the board discussion. So we are just reflecting with NHS England and more locally what that means in practice, and we'll update the board in the next cycle, Chair. We also have some good news around, again, neighbourhood focused. £8 million worth of investment announced in 3 neighbourhood health centres in the east of our patch, and they're named in the report. There are going to be more opportunities, I think, within each of the places within Lancashire South Cumbria ICB to talk about how we use that investment to good effect. I've been out and visited 2 of those centres so far, and you can see the impact that co-location of partners and easier access for patients and the holistic service offering in these centres talks much more to the model that Lynn and Danny were talking around in the leisure centres. So I'm keen to explore what that looks like in terms of our neighbourhood strategy. And then the final update, because I know this will have caused some angst between boards, is you may have seen in the press conversations around the ASD and ADHD assessment service. Really clear with existing providers that that is a service under pressure and didn't have clear commissioning structure around it, which was creating long waits. I am grateful to colleagues in both LSCFT, which is Chris's organisation, and Blackpool Teaching Hospital, 2 of our large providers in this area, who've been working with our clinical and commissioning teams on an interim process that should help with faster triage and ensuring those members of our community that need support get triaged to the right place effectively. And as we work through that, we'll update the board as to what the permanent changes in the commissioning intentions are in this service area. It's important. We've been working with the Patient Carers Forum as well to make sure that's well communicated, Chair. So that's my update.
Thank you. Thank you very much, Aaron. Any questions for Aaron on his report? Yes, Debbie.
Thanks, Chair. Apologies, doesn't seem very loud, but I'll still try. I have switched it on. I wanted to ask a little bit about the Caring Together Memorandum of Understanding, please, because you quite rightly mentioned it as being a really important partnership development between ourselves and key partners around system solutions. So I'm just wondering if you could give us a little bit more information about sort of what that will deliver, what the success measures are around it, Aaron, and how the board might be updated on what the impact is through that moving forward, particularly around being selfish sort of commissioning outcomes and what the benefits would be.
It's a really good question. So as always, when I pull a summary out of my reports, the question's on the one area I haven't pulled out, Debbie, so thank you for that. So this is a big piece of work that I know Jane in particular has been working on with colleagues in local authorities. And it's been designed to, the relationships with local authorities are good and have been improving, particularly in the last 12 months. But it was really clear that some of the, I know this isn't the English language, the stuckness that gets created where there are shared responsibilities or budget conversations was stopping us making decisions quickly. That will have featured in our organisation with either delays in packages or access to care or financial constraints where there's disagreement on budgets, for example. So the MOU is designed to be really clear as to both how we want to operate together in partnership, but what the rules of the game are, so there's no subjectivity and nothing lost in translation. So what we should see is better outcomes, better service access and better experience for those members of the community that use services where we have some joint responsibility in the management. And we should see clearer and cleaner financial flows in both sets of organisations actually that stop some of the angst we can see, particularly around things like year end when we're trying to agree balances. I think this is quite a rudimentary first base, if you will, about what we might want to use this kind of relationship to take forward. So if I mention things like the Better Care Fund, our ambitions around integrated health organisation contracts, neighbourhood development, it's really difficult to get into those quite innovative areas when some of the basics and the core are kind of stopping us progressing in the way we might like. So I'd also see it as a bit of a catalyst to firing up some of that partnership working in those more innovative areas of development.
Thank you. Thanks for the question, Debbie. Any other questions? Yes, Tracy.
It's probably more of a reflection really, Aaron, but you've outlined the changes happening within the ICB. I just wanted to sort of reflect on changes within local government as well, and how there's kind of an instability, I suppose, across two really key areas. I've been joking with colleagues and saying the VCFSE feels like the most stable sector for once, because there's so much change across statutory sectors. I guess it's more about what is the impact at the moment. You just said we're improving relationships with local authorities, but of course in the next 12 months we're going to have the shadow unitaries forming, and then in 2 years we're going to have the unitary authorities invested. I just wanted your kind of reflections on that, really.
In all honesty, Tracy, and testament to the leaders in the local authorities, not noticing a great deal of disruption in either the relationships or the progression of the things like I've just mentioned, moving to a more formal MOU. Only last week I met with 2 of the local authority leaders to talk about how we take forward things like the IHO and neighbourhood development in place. It featured as a conversation to say, but things are going to change in the future. But what I had back was some pragmatism to say, actually, our communities need us to work more effectively, and we can't wait a year or 2 years for shadow or permanent changes. So it's a known agenda. We'll want to work together collectively, and we'll jointly respond to the consultation that's been asked of us in terms of local government reform. But actually what I'm seeing is colleagues working effectively together to make sure that the people that see least impact in that are our communities and the way that we want to work together. So I understand the question, but we're not seeing that kind of disruption currently.
Thank you. Okay, I can't see any more hands. Thank you very much, Aaron. We are now going to move on to working with people and communities. Neil, Insights Report.
Thank you, Chair. Just before I start, we did have a question about this paper from a member of the public. It was in relation to a very specific service change, so just to reassure, we are going to respond directly to that individual. I think the report and some of the contents gives more of a summary of how we're taking some of that feedback on board, rather than specifically addressing that one point. So I think I'll just talk a little bit over the paper. I'll take it as read, but just describe some of the intention and how it links with some other items on today's agenda, and kind of provides more of a bit of a strategic overview. Firstly, in section 2, it describes some of the high-level consistent themes that were received from public engagement activities, different ways that we capture insights from things like complaints or different pieces of work that we do that might be on some specific service changes, and pulls out some of those really kind of key themes and insights that we hear consistently across the patch, and how we have then used that to influence some of the work around our strategic commissioning intentions and the strategic plan. So there's a clear link there. There will be an item on the agenda later about that strategic plan and how we've been able to use insights to feed into and inform some of that work. And that has been through a range of different ways of listening to people. So how we work with Health Watch, how we work with local partnerships, some of the examples that we've heard earlier today and in our community stories about some of the work our teams do on the ground. It's been able to look at those key themes and collate them and bring them into that discussion. The other item in section 3 describes some of the importance of that statutory guidance that we've got around working with people and communities, and how we're making sure, particularly in the decisions that we need to make in the commissioning work that we do, how we're using that to make sure that we've got public engagement involvement and some of those insights fed into that work as well. So again, you'll see some of that come through on some of the items on the agenda around some of the service change, but also some of that way in which we intend to make sure that our commissioning and our decisions do involve people. So as a brief overview of the paper, I'm happy to take any questions, Chair.
Thank you. Thank you very much, Neil. There was some quite unsurprising, but some quite insightful observations in that report, weren't there? Okay, any questions for Neil? Any observations, thoughts? Yes, Debbie.
Thanks, Chair. Thanks for the report, Neil. I think it was really insightful as always, and it's always really rich, and you do a really great job of trying to distill it down so that we can get really complex, rich messages but sort of understand it in a framework. And I was really pleased to see how that then flowed through to the commissioning strategy as well, so there's that really direct linkage. I suppose my interest is around the outcomes of the insight and the impact that it has and how we sort of measure and we understand that. So I'm wondering, in terms of thinking, the report had updated about consideration of the infrastructure around involvement and engagement and insight, and I'm wondering if that'll include thinking through how you might be able to give the board assurance that when we have that insight, it actually directly translates through to commissioning decisions and the outcomes and the difference that it makes. Because I guess there's sometimes a sense that there's consultation and we're sort of gathering the insight, but it's the hard-nosed impact that it has in terms of decisions and being able to impact that and follow it all the way through that I think would be really valuable to be able to see as an evidence.
Yeah, so what I would say is some of the evidence that we see from that probably comes from some of the community stories that we've seen. I think over the last 6 months, all of those examples that we've heard at the beginning of the board are born from some of the work that some of our commissioners and some of our teams are doing on the ground, genuinely taking a population health improvement approach, working with partners. All of those components are really key parts of our statutory guidance for working with people and communities, and looking at Andy because of some of the work that we've done with some of our population health teams on the ground, and that's probably where we get some of the richest examples of you said we did or so what's, where we can see communities have been co-produced or involved in co-production, involvement, engagement, and we're seeing partners coming around the table talking about some really positive impacts from that. I think there's then some of the work that we need to do around some of the process-driven service change examples, and what you'll see later on in the paper on each of those examples of some of the case for change, and even the sections of the board papers where we've got examples of where we've done engagement involvement. We have to make sure that we do those processes to undertake that engagement in the best way possible and really clearly evidence the impact that that's made in terms of the decision making as well. I think unfortunately those processes aren't as quick, they're not quick processes. So I think some of the difference between when we undertake some of that engagement and when we see some of that impact needs to be described through the pre-consultation business cases and then the decision-making business cases that will come through for decisions for the board. And I think in some of the examples we've had, we've been able to evidence that clearly. But some of the richest examples are some of those real community examples where we're involving really early. Is that helpful?
I think that's right, and I think there are different levels to it as well, because I think the neighbourhood areas are, and we need to talk. We need to give the narrative as well. We need to tell that story. But the other part of this, at a more strategic level, I think, I see as a very important role of the commissioning committee, on which you will be a member, is to ensure that all our commissioning intentions are based and rooted, not just in the insights, but in the population health data as well. But the two are meshed, and I think that will be much clearer through some of the new structures that we've got. But good question, thank you, Julie.
Chair, thanks. I think it's really good to hear that as an ICB that we're planning to do this through the commissioning strategies. But I also just feel that we're in a very difficult position, as we've just seen with the GLP-1, the weight loss injections, that though we're making some really good efforts to make things right for our neighbourhood, but if we look in Neil's table and he looks at primary care, very much what patients and service users are telling us, that they would like to be seen face to face. They would like to not use the online technology. However, as an ICB, we're quite held by NHS England dictating really that this is the way forward. So I think we are in quite a difficult position with some of the feedback that we're seeing about what our population is asking for versus what the national ask is. Thanks.
Andy?
Yeah, I agree with that, Julie. It's a good point. And I also think that sometimes when new ways of working with the NHS or services are introduced, I think our public can feel naturally nervous about that. And what's been really interesting when we look at the data around digital access online appointments for GPs, initially people have said, I don't want that. I want to be able to walk into my surgery and have that kind of relational approach. But actually, as they've started using it, the data is now coming back with really, really high satisfaction rates. Actually, it's tearing down inequalities in access. People from our most disadvantaged communities are some of the highest users of our digital access in terms of appointment booking, and it's meaning faster access to appointments and greater satisfaction rates. So it's one of the reasons they think that we've seen such a massive spike again nationally in terms of GP satisfaction rates is better access made possible through better use of digital. So although there was a real reticence from the public to begin with, once we began to do it and build confidence and show people how it worked effectively, actually it's been something that the public have then got on side with. So sometimes, although we can see the nervousness, sometimes we also have to hold our nerve and work with the kind of stuff that's going to make things more equitable and more accessible for everyone.
Thank you. Neil.
Yeah, so I tried to address some of that point in 2.4 in the paper, where actually by understanding and understanding some of the perceptions of our public, that's the reason for the last 12 to 15 months we've done quite a bit of work of understanding perceptions, where some of this comes from. It gives us those ideas of areas of where we need to do more around public awareness, more around demonstrating the change, more around helping people to understand what might be different, but also how we might involve people in that as well. So there is recognition that some of those insights might be areas where that gives us a place where we need to make sure some of our public awareness campaigns help to shift opinions and perspectives and perception that actually shifts to more of what we need in the future around how we might deliver modern general practice. So again, that aligns really closely to some of the information in the strategic commissioning plan, where we absolutely address that we need to do more to actually describe more of what healthcare in the future might look like and how do we work with people to understand that. So I think it's helpful to understand, the engagement work helps us to understand what the public perception is, but it's how do we then work with that and actually help that to influence what we do, and how do we create awareness or shift behaviours as well.
Good point. Thank you. Thank you very much, Neil. Good. Okay, we are now going to move on to the performance section. And where's my agenda? We start with the Quality and Outcomes Committee escalation report, and thanks to Jane for presenting this in Sheena's absence.
Thank you, Emma. Yes, clearly Sheena is the chair for this committee, so I'm presenting the report on her behalf. There are two alerts to draw the board's attention to from the meeting we had on the 4th of March. The first one concerns safeguarding. Excuse me. So by way of context, there's the ICB's own individual responsibilities for safeguarding, but we also work as a partner with other agencies. And safeguarding really needs strong multi-agency partnerships to be effective. And as you can see here, one of the areas that has been flagged as an alert is to do with the backlog of cases in what's called the MARAC conference, which is to do with high-risk domestic abuse cases. So we discussed this in the committee and some mitigations around the police actions that the police are taking to improve this. But a kind of note for ourselves was, as we downsize staffing at the ICB, we do need to keep under review not just our own individual responsibilities in this area, but the fact that we can continue to contribute meaningfully with partners and have the resources and capability to do that. So that's a kind of note for review. The second area for alert was we had a report on the pressures in urgent and emergency care, and particularly kind of winter pressures. And I mean, it won't be a surprise to the board, but clearly there is a sustained systemic-wide pressure on our system, resulting in prolonged waits and challenging care environments. And there are examples of this causing harm and lower standards of care than we would like, and poor morale for staff who are having to work in these areas. You know, the kind of corridor care is a very difficult environment to kind of work in, and so on. So despite that, we did hear some really good examples of mitigation efforts and staff engagement efforts and leaderships. And we also received information about some regional and national initiatives and funding that are designed to address this, so we need to keep that under review. But there are certainly, this is an area clearly where we still need to provide further assurance as we go forward. In terms of advising and assuring the board, couple of things related to all-age continuing care. The first one to note is that we are going to carry out a review in all-age continuing care because we have a higher than expected percentage of patients who were living at home prior to admission, but they're not returning to their own home afterwards. And we kind of need to understand that better. And so some targeted work is underway to investigate and improve this. The other point to note is congratulations to the team on a new complaints process for all-age continuing care. It's streamlined, it's more effective, and it focuses on learning for complaints, and we all felt that that was a really positive step forward as a result of a kind of 3-day improvement event that the team undertook. And finally, just to note that we received an update on quality impact assessments, and I think we should note that there has been significant improvement in how these are carried out and embedded within the organisation, not just paying lip service or, completing them after the event in worst case scenarios, but now they are a meaningful way to kind of embed this within the organisation. Happy to take questions.
Thank you very much, Jane. And it's nice to see that coming through because that's been an ongoing conversation, so that's a closure point for the committee, so thank you. Any questions for Jane? No? Okay, then I think we move to the performance report. Is that right? Yes, integrated performance report.
Yes, thank you, Chair. So I'm presenting the performance report for Asim Patel, who's currently off. There's a very detailed paper with a performance report appendix. I'm not going to go through it in detail, but I am going to just bring out some of the highlights from what is become a bit of a regional spotlight for us recently. So demand in the system, we've just heard from Jane in relation to some concerns from UEC, but there is a general demand in our system that is higher than the demographic growth, and I think we just need to recognise that. In relation to our specific performance, people will heard us talk about elective care or RTT, referral to treatment. At the end of December, we had just over 243,000 patients on our waiting list. There's been a big focus on getting back to 18-week referral to treatment. I'm pleased to say at the end of December, we were reporting that 61.7% of our patients were waiting 0 to 18 weeks. Still further work to do, and we have something called the Q4 Sprint, and that's to help us improve our position for referral to treatment. We still have a couple of long waiters which we're looking to eliminate, and there's a lot of hard work, but we do have some pressured specialities, oral surgery, neurology and gynecology. We're working with our independent sector colleagues hard on to address that. Diagnostics performance slightly dipped in December, but it is still above the national performance, so at 77.4%. I think it's fair to say that we have variance, so we have one of our trusts at just under 57% and the other at just under 99%. So obviously we want to do targeted work to level that out, so I think that's an important difference, that we are working in a bespoke way with our providers. Cancer, in December, the ICB achieved its faster diagnosis standard, slightly below plan but achieving the standard, and the aggregate across the providers achieved the 31-day standard for cancer, which is positive, and overall performance across the ICB was at 70.8%. So in improving position, still some work to do. Urgent and emergency care, we are still slightly under the target of 78%, and we've had a particularly difficult January and February. And I think the teams have been working extremely hard under very challenged positions. We've been in Opal 4 in all trusts at one point, which is I've not seen in my time either in the ICB or previously, so it was unusual set of circumstances. So I just want to say, congratulations to all the teams who continue to deliver high quality care despite that challenges. In relation to ambulances, 80% of our ambulances have had a 45-minute turnaround, which again is positive, and we're looking to improve that position. Mental health, there was only 2 inappropriate placements for the ICB at the end of January, which again, if you look on previous years, is a massive improvement, and Chris might want to comment earlier. We've seen a slight dip in proportions for reliable recovery for some of our services, but that tends to happen in when we're reporting, and the dementia prevalence target is being achieved, which I think is another positive step. Primary care, volumes of GPs appointments in December increased by 10,000 appointments, which was 1.3%. So I think that just goes to show what how primary care are also stepping up, and our ambition in relation to the adult population and children's population to see a dentist were both above our planning trajectory. So again, if you think about our dental plan from a commission perspective, that was our ambition when we're on target to deliver that. Planned care, I've already mentioned, we are still continuing with our long waiters, 52-week waiters, and we'll still focus on cancer and our severe mental illness and learning disability checks for both groups are matching last year's performance. We obviously want to see that improved. So overall, I think a positive picture, but still some further work to go, and a focus from our commissioning and clinical teams working with our providers on driving those improvements forward to meet those national constitutional standards. Thank you, Chair.
Yes, thanks, Craig. Aaron, did you want to come in?
Yes, please. Thanks, Chair. So there's a triangulation there, isn't there, in the escalations from Quality Committee and what we can see in the performance report around urgent care pressures, both in physical health and mental health, actually, over this period. So we haven't got this available today, but it will feature in the medium-term plan conversation, which is our focus on growth and demand management, commissioning intentions, and working in places about how we ensure we reduce that, particularly that non-demographic growth demand for urgent care. It's a big part of our strategic commissioning plan, and we'll draw in all partners at place to see if we can manage that cohort of patients in particular, Chair, a bit more proactively through the period. We have to remember that we've also taken out significant amounts of cost and capacity this year, which means the headroom and flexibility of the system through a winter period has been much reduced. I think we've got a bit of time for, whilst the sun's shining through spring and summer, to take some of those steps that ensures we're in a better position for next winter, notwithstanding the improved position and the work of teams kind of dealing with patients day in, day out. But I think there's more collective we can do around urgent care in particular, and it'll feature in our plan priorities.
Yes, I was going to say a similar thing, which is that, this time we do have, for next year, a triangulated plan for performance that is backed up by finance, that is signed up to by all providers, which is a very, very different place to where we've been in previous years. So I think what you say about still work to do, and there is still work to do in some key areas, that is reflected in the plan that we'll be considering later. Good. Okay. Onwards. Oh, yes, sorry. Yes, Andy.
Just a quick point, really, Chair, which is that last week I was speaking at a conference down south alongside our lovely Chief Medical Officer, Chris Whitty. And I wanted to just make a point to the board, really, about, we look at data in quite short time frames sometimes, and there are some phenomenally encouraging pictures nationally about what we are achieving. So let me just give you 2 examples. If we look at cardiovascular deaths in this country from over the last 40 years, we have seen a 75% reduction in mortality. That's an absolutely incredible breakthrough in science. And we can attribute about 1/3 of that to changes in behaviour in the population, particularly stopping smoking. About 1/3 of that is due to physicians, clinicians, particularly in primary care, being better at finding people with high blood pressure and treating them to target. And about 1/3 of it is because the ambulance trust are so brilliant at getting on site quickly and resuscitation and what happens in the back of an ambulance and getting people to hospital quickly for interventions. And when we look at cancer now, mortality from cancer in this country over the last 10 years is decreasing in every single cancer group now, except for uterine and liver, where we're seeing increases. But we are there, you know, when we look at longitudinal data, there is a phenomenal good news story across the NHS right now in the changes that are being made and how we are, as we follow the science, as we work with the public, as we take an evidence-based approach, as we improve our services, we are making massive differences to health outcomes across our communities, and we are closing health inequality gaps in many of these areas. And I think sometimes we can look at some of the short-term data and feel like we're not doing a good enough job. And in some ways we're not, and in some ways there are always things we can improve. But when we look at the story of what we have achieved over the last 10 years in cancer, over the last 40 years in cardiovascular disease, and we could talk about mechanical thrombectomy and stroke and the huge difference that's making. We could talk about the implications in respiratory disease right now. There are some wonderful good news stories. And in all of the we need to do better, there's also some we're also doing an incredibly good job. And I just want the board to reflect on that and the great difference the NHS is making in this nation every day.
Thank you. Thank you very much, Andy. Silence.
Yeah, thank you. Just to build on some of Andy's comments there, started this week the national data on clinical outcomes for major trauma centres up and down the country was published. Really pleased to report that the best performing major trauma from safety and clinical outcomes is now in Lancashire at Lancs Teaching. And again, just reflect on that 10 years ago, we were the worst performing major trauma centre in the country as well. So quite a turnaround. In addition to that, the fact that we've now got the 24/7 mechanical thrombectomy service live now at the trauma centre, again, is a huge breakthrough. That's been a big gap in our provision. And again, we're one of a small handful of major trauma centres that can provide that. It's not universal, unfortunately, at this stage up and down the country. I know vascular reconfiguration is one of the issues that will be coming onto the board agenda later in this session. But again, that change that we're proposing around vascular surgery will further strengthen the service that we provide, not just to residents in Preston, but for all of Lancashire at that major trauma centre. So I thought it was just worth just putting that on the record as well. In terms of the wider piece of work around UEC, I think urgent emergency care, I think what started to emerge now really interestingly is that when you look at the pathways of our patients are going through, if you're under 65, the experience you have in terms of your time spent waiting in an A&E is probably about the same today as it was back in 2019. However, when you start to look at our older patients, and in particular our older frail patients, that's when you see a real marked difference, and we have really deteriorated in how long frail older patients are waiting. So where we're concentrating as a provider collaborative this year and by individual organisations is absolutely about that frailty pathway. Again, really pleased that we're also one of the 7 national frailty sites that will be working with colleagues up and down the country and with NHS England to improve our care for frail older people as well. So again, worth noting.
Thank you. Debbie.
Thanks, Chair. I feel like a killjoy now asking a challenge question. But I wanted to focus in on the 52-week wait position. And we quite rightly acknowledge in the report that it's still a challenge for us in terms of making the reduction. I think it's really positive in the report that we say that whilst it's not reduced at the pace we would have wanted to in terms of our ambitions, it is obviously reduced and it's below the regional average. And also, when you look at the patients who've been seen, the majority of them are actually from deprived areas, so we're clearly taking a really focused approach. I can see in the report in 3.5 we're really clear about where the issues are. So there's oral surgery, neurology and gynecology, and then the response that's in place around it. I'm just wondering about the timeliness of that response, because when I sort of had a look at 3.6 at what's in place, it mentions planned care commission and elective reform provider initiatives being key, and it sounds, although I'm not experienced and I don't have fine-grained insight into what that is, it sounds like that might take a while. So I'm just wondering about the timeliness of the response and if we're doing everything that we can do as quickly as we could, given these patients and people have waited that length of time already.
Thank you, Debbie. So it does differ depending on the speciality due to the challenges, because it is different across each of those specialities. Some are workforce related, but just to give you some assurance, those specific programmes are already underway. So the planned care commission elective reform provider initiatives have all been wrapped up into the sprint, so the Q4 sprint. So we did have them as separate programmes with separate funding streams. We've integrated them now. I knew it was going to go at some point. And those programmes are already in train. So we are aiming for the end of the year to see a significantly improved position on 52-week waiters. But noting we have some pinch points, but they will continue to be worked on at pace through Q1 of the new financial year.
Thank you. Thank you. Good. I'm not seeing any more hands on the Integrated Performance Report, so we will move on to, I believe, Finance and Contracting Committee. Report from Steve.
Thank you, Chair. I'm not going to go through the report. I think people have read them. I think there are 4 key highlights just to draw out. The other thing to say is they're a matter of history now. They relate to January and February, the March meeting being in about a week's time. I guess the 4 key things or key themes in there, and again we've touched on them today. One is the 25-26 financial outturn. The second being the 26-27 medium-term financial plan. The third being costs associated with all age continuing care. And latter, the items somewhat prosaically called grip and control, but really relating to an organisation's capacity to manage through its internal controls, its financial position. If I start with 25-26, and bearing in mind we're about 13 days away from year end, on the plus side, it's de-risked. There's less time for things to go wrong, the so-called black swan events. However, in getting to the year end, in the last few months, we've been working with providers and NHSE to deliver the plan, which would further a release of about £40 million to support the ICB and the providers, and also ensure the release of the deficit support funding. I think in total somewhere between £100 and £110 million, all of which will be non-repayable by the system as we go into 26-27. There was an original plan at the start of, I guess, Q3, which related to an estate transaction which regrettably failed to pass, which left us looking at really using our own internal resources as a system to deliver that. And typically that meant looking at our working capital, creditors, accruals, etc. to the year end. With 2 weeks to go, I think we're cautiously optimistic that we can deliver the plan. What that means is it will protect the 110 million. I'm desperately trying not to stand on Mark's toes as I'm saying this. But that would see us exit in a positive way and also come out of regulatory supervision into 26-27 and effectively make us masters of our own destiny to a certain extent going forward. I think if we'd have asked for that at the start of the year, we'd have probably bitten people's hands off in terms of where we are now. What that does mean, however, and depending how we do exit the current 25-26 year end, we may put more pressure because of the way costs are accounted for in years into 26-27. And 26-27 will itself be a challenging year. We have the costs associated with moving to the £19.60 a head, something of the order of £40 odd million. We have significant cost reduction programmes we will need to initiate, again in excess of £200, and anything we take forward from this year into next year will just add to that burden. So again, the risk profile will change, but what it effectively means is there is a level of risk associated with delivering next year as a result of exiting the current year. But again, I think we are in a better place, certainly than we were at the start of this year, because there's substantial work already gone on to defining those cost reduction programmes, those waste reduction programmes, and we will need to go further, harder and faster over the coming months to make sure we're in a good position to manage whatever comes from left field as we go through 26-27. I mentioned all age continuing care, again, a substantial and significant cost that needs to effectively be managed. It's over £500 million. So if you look at making savings elsewhere, if you make savings on £550 million at 10%, that's 55 million. if you make 10% savings on maybe one of the other cost headlines, it's maybe 5 or 10 million. So you can see the importance of managing that fairly tightly. And that's done through what's called grip and control, if you like, the control systems in the ICB. And I think we've had some pretty strong assurance through a lot of regulatory oversight over the past 12 months that the ICB does have in place strong grip and control. And that gives us some positive assurance as we get through the end of this current year and into next year that we can effectively manage those financial challenges. So cautiously optimistic about 25-26, that we will hit the numbers we need to make sure we get that 110 million. Next year, 26-27, is going to be challenging and there will be risk, but I think we're in the right place to start to manage that. All age continuing care and other costs will need to be managed very, very tightly, but we have strong grip and control which will enable us to do that. And having said that, I'll happily take any questions.
Thank you. Thank you, Steve. Good to have a Chair of Finance Committee that has such a grip of the detail of what we're doing. I know that Steve Spill, you will come back as Chair of Audit in terms of some of the financial governance aspects of it, but that's a very articulate description. So are there any questions for Steve? Yes, Kath.
Thank you, Chair. It's not really a question, it's more kind of a comment, I guess. And I just wanted to say how much better things are feeling in relation to all age continuing care. I think absolutely the grip and control is important. That's absolutely the same for local authorities, and I speak on behalf of all local authorities. But I think there's something about our really strong relationships in this space and that ability to be able to cut through and actually work in a person-centred way, which is the most important thing at the end of all of this, isn't it? We haven't got people waiting long periods of time for decisions or being distressed. And I think what we've done over probably the last 8 months, 9 months or so is really, really work closer together to make that a better experience, not just for the people receiving the right funding stream, I'll say, because it isn't necessarily all age continuing care, but also for the workforce, those frontline staff who have to try to implement and work alongside those people. So I just wanted to kind of commend those relationships, really.
Thank you. That's really, really good to hear, actually. It's really good to hear. Thank you, because it's, there's a lot of work gone into that. Good. Any other questions for Steve before I move on to Mark to give us the current position?
Nope, thank you. Chair, if I'm honest, I'm not going to say a great deal more. I think Steve's pretty much done my job. I felt like I need to ask Steve some questions, to be honest, rather than the other way around. So I'll just take the report as read. It is very much as Steve's just alluded to. So, month 10, so January within the year. At this point, still a couple of months to go. I think Steve's pulled out all the relevant points. Lots of things to sort of manage within the position. I suppose I will just draw your attention to the fact that in 25/6 we are still judged and managed as a system. So not only have we got our own issues internally with ICB numbers, etc., but it is about managing the system. And Steve, again, has made that point repeatedly about system, position, providers plus ICB, managing that in combination. You will see in the report, obviously, at the year-to-date position at the end of January, quite a few of the numbers are behind plan for a variety of reasons. Some of that is technical terms in terms of deficit support funding, and that was withheld at a certain point in the year. But again, if we can hit the plan at the end of the year, then that will flow back in. We have some under delivery and or operational performance pressures, again, in all parts of the system. So the cost savings were behind plan at the end of January, but again, some plans to recover some of that. Equally, some operational pressures that, again, Craig was alluding to in his report. So the overall position remains that we expect to be where we need to be by the end of the year, but again, lots of moving parts during January, February, March in terms of getting there. So I'm not going to say a great deal more, Chair, to be honest, because I think that would be duplication of Steve's earlier point, but happy to take any questions on the detail. Thank you.
Thank you. Thanks very much, Mark. Any questions for Mark? Aaron?
Yeah, thank you. It's not a question really. So teams have done a great job over the last probably 6-8 months in really getting to a position where we've got clarity on the year end. And I would agree, having been here for 4 months, the grip and control, the performance oversight, and then the commitment from colleagues to do the right thing sustainably has been really positive. The risk when we start to signal at this point that we think we're there is a breathing out of the organisation, and we're still in an underlying deficit position. So my ask of the executive team, and I know the finance committee will be here, is that we don't lose that grit, rigour and focus on value. So whilst it can sound like cost improvement and costs out, lots of the work we've done this year is about value for money, managing the market better, securing better prices, still ensuring access to services in a way that we want our communities to be able to access. So I'm pleased that we've balanced that in the right way. But I think as we move through the next couple of board cycles, Chair, that assurance on the recurrent nature of the change and the grip and control, I'm just conscious there'll be a report from Audit Committee where auditors have said actually at the start of the year some of your control environments and financial governance wasn't where it needed to be. It's been strengthened through the year and you can see the impact of that. So it's just an escalation, Chair, of a concern that if we breathe out at year end we'll lose the momentum and the delivery focus that we've had in the last 6 months in particular.
No, I think that's a good point, very good point. And I think it's also worth saying that quite a lot of where we've got to for the end of this year is non-recurrent. So it is, it is stuff that we've got to keep doing. We're not making recurrent changes, as board members have pointed out repeatedly. So, yeah, absolutely right. Okay, so picking up on feedback that we need a break in the board meeting from time to time, I am going to suggest that we take a short break, back by 25 past, and then we can deal with the strategic items. Thank you very much. Are we good to go? Okay, welcome back. Oh, no, okay. No, they're not. Yes. Are we live yet? We are. No, not yet. No, not yet. No, we're still waiting for Andy. Okay, welcome back after a short break. We are now on the next section of the board agenda, which is developing the system and strategy. The first item here is the medium-term plan, and I'd like Mark to take us through. Thank you very much, Mark.
Thank you, Chair. Just plan to spend sort of 10 minutes running through the update on the medium-term plan submission, which again you alluded to in your introduction, Chair. So really pleased to say that the system has submitted its plan for the next 3 years, albeit obviously the focus on year one in particular. Pleased to say that a lot of system effort has gone into submitting the plan, and to your earlier point, lots of really good working on alignment in a way perhaps that hasn't always happened. So I think that's a really positive aspect of the plan submission. Just to apologise again, both to the board and to the public, we submitted yesterday, which meant we were still working on it pretty much within an hour of yesterday's submission. We were still making some amendments, so unfortunately we weren't able to get the papers out in advance for obvious reasons, and what we've tried to do today is to produce the paper for today's session, but equally a couple of key slides just to pull out the key bits of information, and obviously we can work through that accordingly. So in terms of today's board meeting, a couple of asks of the board really. One, to make sure we can improve the final version of the operational plan. We are inevitably going to get some feedback from NHS England in the next few days from the national perspective, but hopefully colleagues will make note of all of the relevant parts of the plan. And then secondly, just from a technical perspective, we have to approve as a board the ICB capital plan and the intended use of what we call our operational capital. And again, I'll draw that out shortly. Just a bit of governance in terms of the ICB board. So, in summary, the ICB and the system submitted its first draft of the plan back in February. We, again, met the national timelines around that, but we were given the opportunity, as of yesterday, to be able to resubmit and or refresh our plans for a number of areas. So again, colleagues will know that we've spent some time with NHS England regional team, and obviously we've been subject to that national process in terms of strengthening not only our plan and our metrics, but equally the compliance in a number of key areas, which again I'll allude to shortly. In respect to the ICB plan, there's been no significant change both to the financial values, but in particular we needed to refresh our performance and activity measures, which again I will refer to shortly. On the finances, we have maintained the previous plan submission, but we have taken the opportunity to update for a number of aspects of the waste reduction plan, the sort of cost savings as we refer to them, and equally reflecting some of the contracting movements since the February submission. From a provider perspective, again, we're still working very closely on that with each of our providers. Most of our organisations have maintained the same relative positions, but again, there's been an opportunity to update both on finance and indeed some of the operational aspects. We did have one trust in particular, so Blackpool Teaching Trust, who we did need a full submission comparing the February to the March submission. Again, you will see the output of that in today's report. On the financial position for each of the trusts, all have submitted compliant plans with the new deficit control total. So again, that is a positive aspect. But I think I would say, and it does speak to earlier contributions in today's agenda, those plans are with a significant amount of risk and or delivery requirements that need to be managed and mitigated throughout the course of the year. But a really important part, again, that we've signalled our intent to deliver those control totals. I have a few slides just to walk through, colleagues, which pull out the key aspects of the written report. So if you'll bear with me for a few minutes, just walk the board through 4 or 5 key aspects of the system position. So the first one is the financial plan headlines for the ICB. Again, just a reminder of some of the big numbers. So a resource allocation of just under £5.6 billion, 5567. We have a deficit control total of just under £35 million, which means that we need to spend just over £5.6 billion, as you can see on the screen there. We have been doing a lot of work since the initial allocations and or the planning guidance came out in December. Based on the national and or local version of those assumptions, we believe our spend on a do-nothing basis would be around £5.8 billion, so resulting in a gap of around £215 million. And as you can see, we've broken that down into 3 distinct areas of mitigations that we require. One would be the waste reduction plan, so that again the normal sort of cost savings agenda that we would have to the tune of around £127 million. The £19 per head, or the cost of commissioning adjustments, so this is the move that all ICBs have to take in year to reduce down to that £19 per head, or £19.60 as it now is, of around £35 million. And then other mitigations, so these would be other things that we know that we need to do, demand management schemes, decommissioning, etc., in order to close that resulting gap, and that resulting figure is around £51 million. So that is a recap for the board. That is no different to what we've previously submitted. What I would say, since the February submission, that plans in all 3 areas are making good progress. So on the screen you can see our latest position as of the start of this week, so the 16th of March. We are in a positive position now where circa 125 of the 127 has been identified. Good development of plans, as you can see, 73 of the 125 has now been fully developed and is ready to be implemented from the 1st of April, which is a really positive step. 23 million or 22 million is in progress, and a further opportunity identified of just under 29. And again, the task of the team and the work of the internal organisation is to turn those plans from reds to ambers to greens before the start of the financial year, and I have confidence that that will happen, leaving a small gap which again we expect to be closed before the start of the new financial year. So again, back to earlier points about comparative positions, this work compared to 25-6 year, we still had a significant amount of unidentified during the first quarter. Lots of those plans weren't anywhere near green as well during the first quarter, so whilst this is still challenging, we are in a much better position compared to the previous financial year. Just a quick slide on those other 2 key areas. The cost of commissioning, the 1940 or 1960, now including the pay award adjustment. 4 or 5 key actions. One would be the impact of the voluntary redundancy scheme, which again you heard in earlier parts of today's agenda, that we will lose around 180 staff, and the full year impact of that will give us around 12 to 13 million pounds towards that adjustment. We've got a new approach to our staffing establishment, which will come into effect at some point during the new financial year, post any consultation processes, and some associated HR and structural approaches, which we think again will reduce some of that gap. Part of this work is also reviewing reductions in potential external costs that we currently incur. So, for example, commissioning support unit, we buy in a range of services from a commissioning support unit and other organisations. Again, there's an expectation we'll reduce costs on that and a number of other non-pay costs. And then last but not least, working with our partners across the wider region on a range of other do-once and or OPIC models, to help shave costs off in some areas, but equally reap benefits from that. OPIC stands for, I'm going to struggle here, Craig, correct me? Office of Pan ICB Commissioning, just to make sure I've said it right. So again, that's a wider regional footprint for us to work in collaboration with partners, and again, we're hoping and expecting for some contribution from that towards our cost of commissioning adjustment. I've touched on the third area, so these are more generic in terms of scheme development, so demand management, decommissioning, making sure that we've got validation of our acute contracting assumptions and really holding a tight grip on contract management, in particular around the independent sector, and making sure, again, we've got robust plans there. We are embarking over the next few weeks on what we would call a zero-based budget review, so making sure we can absolutely, back to Aaron's earlier point about volume, make sure that we can align all areas of expenditure to our performance goals and making sure they are a good fit, if you like, to our strategic objectives, making sure we've got good alignment there. We're obviously always keen to look at areas of opportunity, so where we do have benchmarking analysis, where we do have opportunities to do things differently, working with national and regional colleagues on some peer analysis and review in those particular areas. And then inevitably we will still need some non-recurrent savings, but again, looking for those opportunities to be brought into the mix as early as we can in the new financial year. The second area of update is probably more significant in terms of change. So this is our performance submission. Again, as you can see from the report, this is a combination of all of our acute and or community mental health provider activity, also brings into the mix out of area and independent sector contracts that we have, and culminates in a ICB level plan submission as part of the system. Pleased to say that in the main, the majority of our performance standards are green and have passed the test, if you like, of the planning guidance for this financial year. We do have a few areas of non-compliance which I'll now draw out. So in terms of referral to treatment, so this is the main sort of elective standard, the ICB has submitted a compliant plan across the 3 years on both, on RTT and on cancer. We do have one trust non-compliance issue, that is around the phasing and or trajectory, as opposed to not being compliant over the 3-year period. So again, we're expecting and following up with the individual trust and with NHS England over the coming days on that basis, and the numbers you will see in the report, and I will show you briefly on the next slide. For diagnostics, we do have a significant challenge in diagnostics. We have met the trajectory, but unfortunately due to our starting point we are non-compliant. Again, you'll see that shortly on the slide, but we will deliver the improvement trajectory over the 3 years. It's just the relative starting point which we'll need to have some follow-up conversations on. For urgent emergency care, UEC, there is no combined ICB performance position, because from 26/7 performance is judged at an individual provider level, and again we do have one trust where there is a non-compliance issue, but again in part that is down to the trajectory over that 3-year period rather than anything to do with individual non-compliance in that way. So again, I'll show you that shortly. And then last but not least, there are a wider range of performance measures. So I've just brought out one particular challenge or two particular challenges that we have. They aren't included in the main table because we do have, as per Craig's report, many performance indicators that we are judged upon. So in the interest of time today. So we are compliant in all areas apart from year 1, which is the 18-week community waiting list, and also mental health reliable recovery. We are compliant in years 2 and 3, but again, we've got some improvement work to do there in year 1 of that process. The table on the next slide gives you the overall position, which I've just described. So you can see the overall ICB performance where appropriate. You can see the individual trust positions. Again, apologies for the acronyms, but hopefully clear to everyone in terms of the individual trust that we're referring to there. So Morecambe Bay for RTT and for A&E performance, and then the diagnostic position in overall terms for the ICB. And again, that's a trajectory issue going forwards. If I move on to workforce very quickly, so this is again one of the key aspects of the operational plan which we have to bring together. We haven't changed our ICB workforce plan, which in the main is due to the ICB staff and indeed primary care and general practice in particular. Just again to draw your attention, there is a ambition to increase the workforce in general practice over the next 3 years. You can see the relative percentages, and that very much aligns to our shift left preventative agenda and implementing some of the schemes that we need to again reduce the overall deficit position that I was referring to earlier in terms of where the value is in the system. From a provider perspective, again, a number of resubmissions have been made. Again, I would draw your attention to the third bullet point regarding overall reductions in workforce in order to deliver some of the national efficiency savings. So 2.4% in year 1, 1.4% in year 2, and a further 1.5% in year 3. So this is a slight reduction compared to the February position, and I think we recognise, you know, the level of change that's still needed. But I suppose it does go back to the overall position of still being a system in overall deficit and needing to take relative costs out of the system. What I can assure the board, and I know individual organisations will be doing this themselves, those organisations' plans have been reviewed internally by each board and by each relevant part of that organisation to ensure that the activity levels and those services can be delivered in a safe and sustainable way as per the processes that would be in each organisation. There is a table just, you won't be able to read that at all, I would imagine, around the room today, but you can see then the relative movements in each of the organisations and indeed the relevant parts to that. So we're still tracked very much on what you would describe as premium pay, so bank and agency rates, that's a key measure, and indeed you can see in the pack the relative movements at trust level. I will just conclude on the capital point. So each part of the system does receive an allocation of capital resource. You'll see that the information there for the ICB in terms of its primary care capital, so 3.8 million in each of the respective years, and then a pot of money called strategic capital, which in effect is to support system change. And we're working with our provider trusts at the moment on a number of business cases by which that strategic case would be used. There is not a lot of discretion in our primary care funds, as you can see. We generally use that to help support clinical service delivery in and across our patch, and we're also looking to make sure that any IT needs and our sort of agenda going forwards about how we make best use of resources is there for us. What I would say is that if there is any resource left available, we want to make sure that is aligned to our strategic intent, and in particular around the neighbourhood health programme in order to improve local patient services. And as I said, the strategic reserve will be used to support and enable those system level plans. I will just conclude in terms of the plan, because obviously there are lots of parts to it. From an overall perspective, I've just pulled out a number of key risks there. So again, constitutional standards, I think you can recall from the table, significant stretch for all partners to deliver those plans over the next 3 years. And we really need, on both sides, both commissioner and provider, for demand management schemes to be a success in order to deliver those levels of activity. I think prescribing in a very catch-all statement is a significant risk to us, both in primary and secondary care. We've mentioned already some particular issues that we know that we're going to face, but I think the growing trend there, and one that needs mitigating very much so. Continuing care, we've made fantastic strides, I think, in 25/6, but the work continues. Kath has already made the point about how we're working better together on a number of those arrangements, but you know, the population is growing in terms of its age and its overall size, and we need to continue the good work there. There is some work to conclude on London Disability Pooled Funds with a number of our local authority colleagues. We're working closely with them in the coming weeks to try and conclude what new arrangements might look like, and I think that will give us again a better system approach to some of those different arrangements. What I would say on the last 2 bullet points is one weakness or 2 weaknesses in our plan would be our plan perhaps doesn't support as much as we would like on the shift left prevention agenda in year 1. We're very much about trying to move towards that during the latter part of this financial year, and obviously into years 2 and 3 of that. And again, that zero-based review, we hope will start to release some funds where we could do so. And I'm very conscious again of the recurrent, non-recurrent balance in our financial plans. Some of the 25/6 impact has been because of the non-recurrent delivery, and we need to guard against that as much as possible in the 26/7 financial year. Last slide on next steps. So plan submission was due on the 18th. Again, pleased to say that that was submitted. We do have a range of contracts that now need to be agreed and signed by the end of March. We are well on with that. We do have a number of outstanding issues, but the team are working through those at the moment. Not currently aware of any significant items for escalation that we're not already aware of, but again, we'll work with partners on that basis over the coming week to 10 days. We are reviewing our internal governance, in particular the new IMT, as we would recall it. So IMT stands for an Incident Management Team. I think the incident has well and truly passed, and we're now very much into business as usual processes, so we're looking to reframe that. That meeting will get regular updates on those 3 areas of mitigations, as I've just touched on. So the WRP, the 19 pence per head, and those other mitigations will be in place from the 1st of April. An enhanced contract management process. So again, the regime that we have for 26/7 is very much back to money follows the patient, activity times price. So a real strong grip on contracting and activity management plans, which has been a real success for us actually in the last 6 months with our independent sector contracts in particular. I'm really keen to get into that with our new structure as well. I've already touched on demand management and commission approach for Q1, and I know we've got items later on the agenda today. And then last but not least, some work to continue the work on creating transparency in our system, so deconstructing the block. So this is where we have residual block payments still being made out to providers within the system, and I want and need to really understand what that value is associated with those block payments. So a real good piece of work, and again I would just say really collaborative work that's been done in and across the provider sector. So the provider collaborative are leading that piece of work. That's not being done to the providers, that's very much with them on that basis. So a real positive intent there for Q1. So that hopefully brings the board up to date with this week's submission. Lots of numbers, lots of moving parts, but Chair, real good success, and now it's all over to the implementation and the delivery of those plans. And again, we'll work very hard on that basis over the coming weeks and months. Thank you.
Thank you. Thank you very much, Mark. Aaron.
Yeah, thank you, Chair. I will sound like a stuck record, I think, a little bit today, but it's stark, isn't it, that the national planning submissions only really focus on about half of our expenditure. So although the start of the slides talk really clearly about the full £5.8 billion we have, all of the targets associated with the plan are largely cancer diagnostics, RTT, urgent care. But you can see clearly where the investment is being put forward. So for example, 605 million into mental health, LD&A. You can see where we're putting work into primary care expenditure. So there is a breakdown of where our budget is getting deployed, but we don't have the same focus on performance or value. And that's a worry for me, because I can't give the assurance needed, I don't think, on risks, issues and the outcomes we're looking for all of our communities. I said this at the last board, but we are working towards a very different performance pack and a finance pack that draws out those broader areas of the market. It's fair to say, even in the way that we've articulated the performance targets, there is going to be investment in other parts of our system, like BCSFE, like community, like others, because we cannot deliver those outcome targets without the investment we need in other parts of the system. But I'd like to find a way of making that more transparent and visible. It's just the templates and the direction you get for this kind of assurance work lead you to this kind of product. But I'm confident it's there. We just need to find a way of bringing it more into the board's purview, Chair.
No. Thank you. Very helpful. Comments, thoughts, questions? Tracy.
Thank you, Chair. Thanks, Mark. Really comprehensive report there. I just want to understand a little bit more about the kind of support as a system that we're receiving, and also how that kind of interacts with the fact we're reducing our headcount so significantly. And I know the ambition is to move into a financial position where we don't need support around WRP, grip and control, and all the things that we have at the moment. How are we transferring some of that knowledge and skills into our organisation so that we can do all of this for ourselves going forward, whilst at the same time taking a lot of expertise out of our staff base?
Thank you, Tracy. Really good question as ever. Yeah, a couple of things. So the turnaround regime, if we can call it that, has definitely brought us areas where we weren't perhaps doing as well. So certainly if I talk from a financial lens, there are lots of ways that they interrogate our data, the analysis they provide, and I'm going to use the term run rate analysis as an example, which wasn't custom and practice in the NHS, I would say, and I think is a real advantage. So what we're really keen to do, and I'm sure Chris and Silas would comment on this from their own experience of IAG meetings. You know, they have a way of helping us in understand our numbers that we perhaps didn't look at in a different way. We're embedding that in our approach. So again, if I talk about the finance reports, the run rate analysis will continue. We'll continue to develop the reporting regime so that we really focus on those. So I think in those instances, definitely keen to build on that learning. I think the other area of the support perhaps moving away in the next few months is that we need to make sure we don't lose that momentum and that grip and control. So some of the governance changes that I was talking to is about really embedding that in our day-to-day practice. So there is nothing like preparing for an IAG meeting compared to perhaps the internal meetings that we would normally have. And I think we've got a real scrutiny on the way that we need to transact that going forwards. I suppose what I would say is that during this transition, and it will be a transition of the changes that you've just described, there might be times and there will be times where we will need to bring in some extra resource just to try and keep us going forward. So at the moment, as an example, in our internal planning, we've got some extra help just to try and give us some capacity to review plans, make sure they're being embedded, make sure they're being implemented. So I think we'll have to call off some of those arrangements from time to time to make sure where we spot a gap. I think we will also have to invest in systems a little bit more as well. So we need to be really smart about the way that we're transacting data, the way that we're moving things forwards, and where I'm going to use a different example. In contracting, for example, I think we're still very manual in some of the things that we do. I know there are systems out there that can really capture contracting information and allow us to report that in a much smarter way. We probably don't do that as well as we could. And again, with the new model, the new structures, we need to really think about how we're doing that so that we don't necessarily need headcount in the same way, but we're hopefully using the resources, the physical resources in a better and sharper way to use those outputs to move us forward. So a number of examples, hopefully, about how we can embed those systems and practices. I would finish by saying artificial intelligence is definitely something we need to explore as well. So how can we be really smarter? I'm sure if other colleagues were around the table today, we're already seeing instances where we're using AI to look at our data and our validation of information in a way perhaps that didn't exist 12 months ago. And we all know the pace by which that's developing. So technology is going to be really key to us to absorb some of the changes in our manpower and or woman power and or other resources that we have in terms of moving that forwards. Hope that's okay. Thank you.
Aaron?
Okay, so Mark has just articulated really well the value added in the recovery support programme, but there's something different that we'll need in the future. So it's not just about replacing what we've had in the change. So if you think about the strategic commissioning plan that we've got here, market management, payer function, and that really understanding where value is driven from colleagues we were talking about with the leisure centre example. The strategic commissioning development programme that's going to launch in May nationally is going to touch every part of our organisation. So I think the way that we then use the allocation we have more effectively is the way that we would want to drive better value in our system and better outcomes. I think at the minute we're kind of at that foothills of grip and control, cost reduction, tighter contract management. I think there's a developmental agenda that's a little more strategic that will develop over the next 12 months, but conscious we're going to have to change, reduce, stay focused and develop the new world in the same 12 months, which is featuring as risks in a number of areas, but there's as much in the developmental space as there is in the replacing what we've had this year space.
And I think I would add to that some of the changes that we're making to the governance structures as well, which will streamline the way in which risks are escalated and discussed. So I think it is there is a lot of change underway, but I think it's it's a good question though. Good. Yes, Kath.
Thank you, Chair. Yes, so honestly, I suppose what's really incredible is I read the report obviously before the meeting, but then listening to you playing it back, you could actually overlay that over the top of local authority plans that are coming out at the moment. They're so similar, that whole ethos around prevention, around reduction, but the need to still deliver quality services, but do it differently and new ways of working. So I guess what I just wanted to do is just to highlight in this space, we've got a huge opportunity in front of us, haven't we? I know we've already had the pleasure of meeting a couple of times, Mark. But if we do this together, then I think we have got opportunities, haven't we, together to identify those good outcomes and make best use collectively of the resources that we've got. and now more than ever, I guess it's just that relational piece. Relationships are never more important than they are at the moment.
Absolutely. Good, good. I just wanted, I know I said this at the start, but I do think this is quite a significant submission, actually, both in terms of the timing, in terms of the level of detail and setting ourselves up for next year, but also in terms of the work that's gone across the system. I know you've done a lot of convening work, Mark, and I thank you for that. But I'd also like to thank Silas and the Provider Collaborative Board because it's has been a team effort. Now the hard work starts. Good. Okay, let us move on to. Oh yeah, sorry, Steve. Sorry.
Coming in a bit late. Mark, in one of those slides, the WRP slide, there was a line other. It was in the red column, but it was other. You were the executive lead. There was no SRO, that's TBC, and that induces in me my professional scepticism because it almost balanced. It was almost the figure you wanted to find as well. So are they real opportunities there?
Thank you, Steve. So yes, they are. They are later in the pipeline than the others. I think that's one way to describe it. They've all got a PID document, a project initiation document. They come from the benchmarking, the opportunities, the productivity pieces that we've got. So they are to be aligned and distributed out over the course of this week. They will flip into the other sections, and we're working with the SROs, the execs on that basis. So there's nothing hidden, and by the time of the next report that'll go to Finance Committee, you will see those played out in that particular way. They are just later in their development compared to the other schemes.
Good, thank you. Okay, so I think we now move to the strategic commissioning plan. Craig.
Thank you, Chair. So our 5-year strategic commissioning plan is a part of our medium-term planning submission, so it's a nice segue from all of the detailed work Mark has just described. What you've got here in front of you, just to orientate to the papers, is that 5-year strategic commissioning plan, but also Commissioning for Success, which is what we've described as our 26-27 strategic commissioning intentions document. So rather than bringing 2 documents, we've integrated this time for board. You will see in section 8 that we've detailed our full commissioning intentions and how they are aligned. So it's really important that they're not seen as something separate. We have a 5-year plan, and this is the year 1 prioritisation. It is a live strategic document, so it has to be in tune to the changes both nationally, regionally and locally, and it will be continued to be iterated, and I'll bring updates back to board. So it needs to respond to policy changes, the financial landscape, operational pressures, etc. So we want it to be not just a reactive document, but something that it isn't just on the shelf. It's usable for commissioners and clinicians and partners. It starts to describe in detail and the sources, the clues in the title, where we want our strategic intention to be for the commissioning of our services. So very much how do we want to allocate our resources, but more importantly, what outcomes do we want to achieve and how will we measure impact? Because I think you mentioned earlier about delivery. That's been one of the areas that we've really focused on this year, and I think measuring the success is going to be key going forward. It's absolutely congruent with the clinical strategy because it needs to be driven by that clinical strategy, but also very in tune to neighbourhood health plans and integrated delivery plans across our local authority partners, and that will also be governed through our health and wellbeing boards. So it's still developing in line with national requirements. There's ongoing collaboration, and I think there's been a lot of collegiate work on this particular development. So I do just want to say thank you to Jane Cass and Jess Williams in the team and others who have really done the heavy lifting in this space to pull together what I think, when you read it, is a really succinct document that does describe our direction of travel. We've also changed commission intentions for this year to frame them through our 3 shifts across the life course. So again, maps to our integrated care strategy. That's a part of our partnership with our integrated care partnership and our local authority partners. We've also developed a focus on population health outcomes, as I said, but we've done some targeted outcomes for particular areas, children and young people, etc., mental health. There's always going to be an ongoing balance in relation to how we deliver national priorities. It's something Aaron has just mentioned there, that tension that you have between, you look at 5.8 billion, but only maybe a handful of strategic measures. I think our document does much more than that. And in the delivery plan and reports, we'll tease that out, and we'll link it to the work that all the work Neil's teams does in that intelligence and in listening to our communities and how we're measuring success. Finally, this will be ongoing engagement. I don't like the word socialisation, but getting everybody familiar with the plan. And when we've looked at the plan, we've linked it to our operating model for the future, because our teams need to be able to deliver this. So we've absolutely had one eye on what does the future configuration of the ICB look like in partnership with PCB and providers, but also the regional teams and the national ask. And I think that we'll be deploying our commissioning resource as described in this commissioning plan. I'm happy to take any questions.
Thanks very much, Craig. I really enjoyed reading this. I think it's a good document. Questions for Craig? Yes, Kath. Thank you.
It's not a question again, but it's just to recognise Craig and say thank you really for that collaborative approach. I know certainly Westmoreland Furnace, we had representations in those sessions and the feedback was really good, so it's good to see those voices are kind of recognised and fed back through this. And just to pick up on the section as well around the market sustainability, I think there's great opportunities there for us. If we negotiate together, we can one voice. We're louder in the space, aren't we, and better able to get that value for money. So, but yeah, thank you.
Thank you very much, Chris.
Thank you, thanks, Chair, and thanks, Craig. So I think just two things, if that's okay. One, I think Aaron mentioned before around the national priorities and then in the medium-term plan, and it isn't as loud for community, mental health, learning disability and autism. I don't think you could say the same for this document. I think it is woven through it, which is really, really positive. And so I think a history that this ICB has had, which is really good. And then the second point is on page 134 of the pack on the medium-term plan, financial sustainability. I think it is really honest where it says that actually this year is about grip, and it isn't about transforming, it's not about resetting. I suppose it's incumbent for all providers and the ICB to make sure we deliver again this year, because otherwise we put at risk the reset and rebalance, and we'll be perpetually in this cycle of non-recurrent rather than transformational change. But I think it's a really good document to go forward on.
Yeah, that's absolutely spot on. And I think putting it in those terms of this is about developing a stable platform, but actually if we do not develop the stable platform this year, we will not be able to do the transformative stuff that we want to. And I think it's really important that that is really strongly communicated. Steve.
Thanks. And Craig, I also enjoyed reading the report. It's excellent stuff. This is a fairly fundamental question about commissioning. You talk in the paper about shaping the market, which I understand the concept. But, you know, if we're commissioning acute services in Blackpool, or if we're commissioning, I've got a map of Lancashire in front of me here. If we're commissioning general practice services in Bamber Bridge, for example, there's really only one game in town, isn't there? What market is there to shape for acute services in Blackpool, for example?
Yeah, so I do think if you look at urgent and emergency care in Blackpool, we do need to look at the whole pathway, which isn't just about Blackpool Acute Trust, although lots of people will consider the front door in A&E. Actually, we all know that's about more work in primary care. We've done a huge piece of work with our capacity investment fund for UEC with the third sector and voluntary sector that we're increasing this year. What we want to do in shaping the market is say, that's our outcomes we want to achieve, that's the specification, and that's our envelope. How can you do that as a collective set of partners and bring something back that we can then negotiate with? So it's rather than being prescriptive, we're being more flexible to allow better use of resources, because we found we get better results, and we want to do that at scale, but it isn't something we've done at scale to date, so it's a part of our growing commissioning. That commercial acumen really needs to be strengthened, and we may need some new skills and capabilities in the organisation to do that, but I think it's absolutely the right direction of travel.
Thanks. Aaron?
Yeah, Craig's picked up one of the points I was going to make, Steve, but that description of acute services in Blackpool or primary care, that's contract management. The way that Craig's just articulated, we need to move away from providers being viewed as the market and look at our community's real needs and underlying drivers of those needs. We then need to be really articulate into the outcomes we're looking for and approach the provider sector, acute community mental health, VCSFE, community, local authority, under a contract framework. We use the term integrated healthcare organisation contract. It's not a organisational form, but signalling to the market that this is the kind of work we want to do with these outcomes, this is the budget available. How do we get into a position where these whole pathways or stratifying our communities is viewed as the response that we look for, not iterations of each year talking about points of delivery and HIP operations, etc., because that's what's driven us to where we are now. I think the other thing we can be better at, and it'll be in that strategic commissioning development space, is understanding what we're looking for. So it's not just passive with an ask. We need to be better at exploring best models, innovations, digital. Part of the work's going to be that horizon scanning, so we can go to the market with actually a bit of a shape of what we think is possible, so we know what kind of measure of success we're expecting back. That's a big ask from where we are now. So the point I was making to Tracy's question earlier around how do we ensure through the change that we retain some of the things we've had. I don't think we've had anything like this, and we need to develop it. So for me, this year is as much about developing our skills and capabilities in this kind of work as it is in the restructure. So I know we use terms like market management, payer function, system convener, as if everyone really understands what that means and how it might have an impact. We're just starting to build a story with our teams as to what we're looking for in the future. So that's the kind of information and assurance the board should be expecting to see in this next phase.
Yes, please.
So I read about the IHOs in the report, and as I spend a lot of time putting acronyms into my AI apps because I don't understand, and it came back with doesn't exist, maybe a bit of jargon. So what and that literally ChatGPT telling me that this, what does an IHO look like?
It doesn't look like anything. It's a contract form. So I think where people have got a bit hung up on the policies, when this was released, it was released under the same discussion as foundation trusts being reborn. And a lot of organisations, I was in a provider at the time, looked at getting a new FT assessment and then becoming an IHO, like an integrated organisation. The policy moved quite quickly to recognising this as organisational contracts, not a form. So, for example, we're talking about commissioning in 4 places. So to go to the place, you will have acute and community providers in there, but you'll have Chris's organisation represented at place, you'll have local government in place, you'll have VCSFE in place, and we'll want to go to that place with an offer to convene themselves under an IHO contract. We might test it, Steve, with children's services or respiratory pathway, with a really different way of wanting to use our resource to deliver different outcomes. And we will only offer back to the market when we see an integrated model come back from those partners. So it forces, if it's needed, and it isn't in some areas, convening of pathway partners to come with better value for us. That's what an IHO approach is, but ChatGPT doesn't always have all the answers, I've noticed.
Thank you. Yes, really good question, Steve. The point I wanted to make actually relates to some of that market development, so really interesting on your answers. Like Kath, Craig, I just want to give you credit really for this strategy that absolutely has a thread of VCFSE running right through it, because we've been involved in the development of it, and that is really positive from the sector's point of view. I think a couple of things, that market development piece really interesting, because I think the way in which we've developed our relationship and the way it's evolved is, and again the strategy really speaks to that, is the VCFSE sector and through the Alliance want to be absolutely one of those partners that is helping you develop the market and understand the potential of our sector as not just a deliverer of services, but actually as a commissioner as well. And that's some of the work we've done already around UEC, where the VCFSE Alliance has been given that role really and freed up that ability for us to understand need and then be able to commission through our sector some of those services. And I think what you asked about acute services in Blackpool, when we think about those clinical pathways, we haven't always been able to build into the market alternatives. So whilst we think very much about the way you described it, there's no other provider, I think there are so many other providers, particularly if we think about aligning it with prevention, so people don't end up at the acute service always. So I think there's so much potential in that, and it's about being able to unlock some of it. And again, I think we recognise there's a real role for the VCFSE. I'm really glad, Aaron, you picked up on place and the framework about moving finance into place, because again, I think that the strategy obviously talks about that, but until we get to a position to do that, we're not going to realise the full potential of what we can unlock. And again, that's absolutely growing those services based on need, not building clinical pathways in the way that we think they should be built. So I don't know, Steve, if that helps a little bit with your question, but I certainly very much welcome that shift away from the VCFSE sector being seen just as a delivery partner and actually being in that space around let's have those early discussions and let's work together building our skills at commissioning as well.
Great, thank you. Jane.
Thank you. Likewise, thank you to Craig and the team. I think this is an excellent document. It's really a really good framing document for what we're trying to do. I want to make a plea, actually. There's a section of this that's about enablers, and they are so important. You almost like turn it around, put them at the top instead of the bottom. And the enablers are things like workforce, training and development, skills, all those kind of things. But I always make a plea for that. Today I want to make a plea for innovation. I think there's a real danger because we've been so focused on planning and taking cost out and doing things we've always done but with less, that we don't think about innovation. And doing things differently in its broadest sense is about how we're going to make real changes here. And the way we commission as opposed to contract allows scope for innovation, doesn't it? So I know you know, and I'm just making a plea. I'm not telling you anything you don't know. But I think, we heard about, it's not just AI type innovation, even small innovations, the way we do things can make such a huge difference. And I think we have to foster these kind of cultures in the way we commission going forward. So.
Thank you. Yep, I think that's very much aligned to the thinking. Roy.
Thanks, Emma. Yeah, it's a great document. Thank you very much, Craig, for it. It's very comprehensive. Commitment in there to working with health and wellbeing boards on commissioning at locality level. And you're obviously aware, I think we talked about briefly earlier, local government reform. So there's going to be some changes coming, but we don't know realistically the timescale on that and when neighbourhoods are going to be put into place. So is that going to stop us enabling some transfer of resource into places so that actually they can get on with some commissioning some of that at that locality level and changing things, certainly in some of the deprived areas that we've got within our communities? Thank you.
No, Roy, I don't think it will. It will stop it. I think we've just got to be mindful that there is still parts of the landscape that are undecided, that what the future may look like. However, our intention is about looking for population commissioning and how we do that through neighbourhoods. We've already got some neighbourhood pilots that are thriving. We want to grow those further. We want to look at as commissioning for outcomes with specifications where we stimulate the market to come back to us to be more creative. And to pick up Jane's point, innovation is really important. We've got the stability and continued delivery year, but we all know that we want to get into transformation and innovation. So it might need adjusting. We might need to course correct depending on what happens with local government reforms, or what happens with parts of the commissioning landscape, or even as IHOs emerge. But I think this document's flexible enough to react and respond in a way that doesn't stop the sort of us driving this forward and achieving our ambitions as an ICB.
Thank you. Kath?
Yeah, I just want to support what Craig's saying, really. So, yeah, obviously there's lots of change, isn't there, right across the whole of the system, and some of it feels a little bit like chicken and egg or horse and a door bolted, whichever way around it is. So we can't wait. I mean, neighbourhoods, there's been lots of work happening at neighbourhood level for a long, long time, not just because somebody's decided suddenly to put a label on it and call it neighbourhood. So I think if you were to, if we came, we could bring lots and lots and lots of examples that are already happening. And just in terms of the health and wellbeing boards, there's good representation there. I mean, we have got some complicating factors in that there's more than one health and wellbeing board on the Lancashire and South Cumbria or Bay footprint, however we want to phrase it. And we've been waiting for guidance to come out for the chairs of health and wellbeing boards. I think that came out yesterday. I've got a document that said it did. I haven't read it yet and haven't had the chance to put it through Copilot yet. But so the information is coming, but I don't think it is in any way, shape or form holding us up. We're getting on regardless, and regardless of boundaries, we're just cracking on.
Great, thank you. I just wanted to pick up on the enablers. You mentioned the enablers, and I'd agree with you. The other thing that struck me about the enablers is that I think 3 out of 5 aren't actually within our direct control with the new model ICB, which means that there's an additional risk there for us that we need to manage. I don't know whether either Craig or Aaron, you would like to comment on that.
So in the blueprints for ICB and region, there's some delineation, isn't there, as who has leadership responsibility, and in the estates and digital and some elements of workforce, the overall accountability and responsibility for strategy and oversight is sitting at region. That doesn't mean that we won't have access to and the ability to drive and shape and ensure we've got those elements within our plans. It just means the teams and the resources will sit elsewhere in the blueprint. I think one of the things that you touched on, Jane, and in Craig's response, I'd really sponsor, which is it's all too easy when we talk about an estate or innovation, we then set up a task and finish group, we want a committee that oversees it. I do think it's in the development and the culture of the commissioning development programme that we dip people in at a regional level, that we can take some of the skills and capabilities back into the service design and the way we work. But it is fair to say, Chair, I think that the responsibility and resource now is going to sit elsewhere for some of these issues. We need to make sure we're an engaged and informed partner in driving what we need to get our strategy delivered. Yeah, that's a good point.
Yeah, thank you. Thank you. Okay, I'm not seeing any further hands, so we will move on to the next item. So actually the next 3 papers present cases for change, and I just think it's worth just explaining how these fit into our decision making. So there are clear prescriptive processes that must be followed for any service change, and they depend on the scale of the change and the likely impact on patients and the public. So these cases for change, they're all different, but they've been developed either by a trust or the provider collaborative board, and they represent a request from a provider perspective for our approval, the ICB approval, to proceed with the relevant process for that service change. So I really want to stress to the board that this is the first step in any substantial change to services. An ICB approval on any of these won't necessarily mean that the changes proposed will happen, just that the process can proceed to the next stage where there'll be further opportunity for engagement and involvement of staff, patients and communities. The role of the ICB at this stage, therefore, is to decide whether there's sufficient merit in the case for change to justify further consideration. And in making this decision, we need to consider whether the proposed change will further the strategic commissioning intentions that we have just been debating, that it will further our core purposes of improving outcomes in population health and healthcare, tackling inequalities in outcomes, experience and access, and enhancing value for money and productivity. And I just think it's worth just sort of placing that before I hand over to Craig to take us through the individual cases. They're all different, as I say, but they all fit within that overall framework. So over to you, Craig.
Thank you, Chair. I'm going to watch that back because you did it brilliantly, so I'm going to use that frame for the future. So you're absolutely right. This is a request for us to proceed with the process. Just to give a little flavour of indicative timelines, although the date's slightly different on all of them, but this has already been through executive discussion within the organisation and through engagement through our scrutiny committees with our local authorities. So it then comes here for approval for the case for change. It then goes to what we call a stage 1 assurance with NHS England, and then if they do a strategic sense check and say yes, they support that decision, we then go to what we call a pre-consultation business case. After that, there's a stage 2 assurance by NHS England, and then it will come back to our board. So there's quite a lot of steps that we need to follow through the nationally prescribed process. If then, after the board makes a decision, that's when any formal public consultation would occur, and that's then when we go through the decision-making process post that consultation before any changes were made. And there is a final stage 3 assurance from NHS England to check the process has been adhered to properly. So that will apply to all of them. So just in relation to the 3 separate ones, we have one for Furness General, which relates to level 3 critical care services. So a decision was taken temporarily to limit critical care at Furness General to just level 1 and 2 care only. This happened on Monday, the 23rd of September in 2024, due to patient safety risks. This was supported by our critical care network, the ICB and the Trust's executive team. This is not to say if patients who have level 3 critical care needs at the time aren't treated, they are, but if they've got ongoing needs, they are transferred to Lancaster, stabilised and transferred back. So it's not, they are turned away, and it's not closure of critical care. It's certainly not anything to diminish Furness General. It is about making permanent an arrangement that's now been in place for 18 months based on issues that relate to clinical safety, workforce and meeting core standards. But that case needs to be considered properly, but the Trust has asked us to consider a case for change to make permanent the arrangements we've already got in place temporarily. Do you want me to pause after each one, because I'm just thinking they are slightly different and it might be worth.
I think we should. I think because they're three items, so we'll take them one by one.
Okay.
Yes.
And just to say, I know there's been a question relating to this particular case that relates to our engagement with Barrow and its significance in our national defence. That would all be considered, A, as a part of any pre-consultation business case, and also any consultation. All of those elements would need to be dealt with properly and thoroughly as a part of that engagement process and be fed into any decision making. So not suitable for now, but absolutely has been noted for any future process that we might need to follow. But I don't want to preempt the outcome of the board today or next steps either.
Thank you. Okay, so questions from board members on this? Are we happy to approve this case for change? Aaron.
So, Oh, got it. Okay, thank you. So it's just to, I think the point that you framed, Chair, and Craig's mentioned, I know I need to declare some history here, having been Morecambe Bay's Chief Executive as part of this financial year. The amount of engagement and consultation with a small C that's already happened up to this point with the communities and others is significant, but there is an absolute requirement for us to make sure that we follow the due process that Craig's just articulated. I think it's important that the case for change is really laid out, for me anyway, the clinical issues around this from a access, safety, workforce and maintaining standards perspective that will play out now in the formal governance process that will follow, subject to the board discussion now on approval or otherwise for the case for change to develop. So I just thought it was important to make that point, that this is clinically driven, particularly with the input that we've had from the Critical Care Network, and latterly the Clinical Senate had also looked at this in terms of the proposals that are being made.
Yeah. Yes, I mean, without wanting to to repeat what you've said, when I read the case, it seemed to me that what we are looking at is how do we best provide level 3 care for the people of Barrow? How is the best way of achieving that? And that's what this case is about. Silas.
Yeah, just to come in, because one of my other jobs is the chair of the critical care network across Lancashire and South Cumbria, and the paper does draw out the work that we've done in conjunction with the Trust and with the ICB. Aaron's right, this is driven by clinical concerns over the sustainability of the current model. And I think what we also just need to remind ourselves, what we're talking about here is the very rare but life-threatening situations where the full intervention of a critical care team and the suite of services that fit around that. One of the key things there is that it's essential that you have the right clinicians with the right training, the right credentials in place. And at the moment, currently, unfortunately, the Trust is unable to provide that on a consistent basis and has a long history of being unable to recruit substantively to those posts with heavy reliance on locums as well. There are really good processes around stabilisation of patients, both on site and then working with our colleagues in the both the North West Ambulance Service and also in the Air Ambulance Service as well. They also play a critical part here, given the geography of the surrounding areas, basically. So again, I just want to make that point on behalf of the critical care network. Thank you, Chair.
Thank you, Silas. Kath.
Yes, obviously I've got an interest with being the Director of Adult Social Care for Westmoreland and Furness, so the impact for Barrow and Furness residents is significant, but I guess it's kind of the narrative that I've given throughout this meeting. When this was first raised through the Adults Health and Care Scrutiny sessions for Westmoreland and Furness, it was very much we sat side by side. I think I actually sat next to you, Aaron, at one point. So we have done this together. It is obviously a really sensitive subject for those residents, and for members of the board who aren't aware, there's been some more situations that are developed in Barrow and Furness recently, with the loss of the market hall as well and the forum being closed down, so some pretty significant buildings that are currently out of action. So it will be noisy, it's going to be noisy, and I think that some of the narrative hasn't been helpful, that just generated through social media campaigns about what the reasons are behind this, but the message throughout has been really clear. It's been about that clinical safety aspect, so I just wanted to give that perspective.
Thank you. Thanks very much, Kath. Okay, I'm going to ask, I'm not seeing any more hands at the moment. I'm going to ask, are we happy to approve this to go to the next stage? Yes. Thank you. Okay, next one. Craig.
Thank you, Chair. So this is in relation to Royal Lancaster Infirmary, and it's with regards to a ward closure. And for those who will be familiar with provider services, ward closures do happen quite frequently. However, this is about closing a 24-bedded ward. The ward was initially a rehabilitation ward, so that's what it's commissioned to do. However, it's being occupied by patients who are delayed and who have ongoing either intermediate care needs or therapy needs. They shouldn't be having their needs met in hospital, they should be having their needs met elsewhere. So it's about the appropriate setting and therefore being able to close this ward to utilise the resource differently. This isn't about job losses, just for people's reassurances, and it will help with some of the agency spend to keep this ward going. We have done quality impact and equality impact assessments by the Trust, and this is a part of the overall management of the Trust, in also considering what we've previously discussed in our commissioning strategy about shift left, more services out of hospital. This would be a product of doing that. So whilst we're all committed to that, we also need to know some of the consequences are changes in the architecture of our provision services, so i.e. wards and beds. So this again would be something that we obviously want to support for further engagement and development to understand the full impact. But that was just to place it into context of this is in line with the National 10-year health plan, and I just think we need to be mindful when we're seeing some things like this rather than look at them in isolation.
Thank you, Craig. I mean, I think as a wider point, you talked about socialisation and engagement of we need to really explain that, because it will come with, there will be positive things coming, and then there will be things that people may not initially, like you were saying, want. We need to explain how the whole thing fits together, and how we're not going to achieve our vision by not changing anything. And I think there is something about the way in which we communicate going forwards. But that's a more general point. So any comments on the case for change for the Royal Langstroth Infirmary ward closure? No? Are we happy to support that to go to the next stage? Yep, thank you very much.
And finally, vascular services. So in essence, this is about, we have a dual-sited model for vascular services. I just want to say from the outset that those centres at the minute do provide safe services for their patient cohort, but they're not going to be compliant with the national specification if they're working separately. So these are currently provided by Lancashire Teaching Hospital and East Lancs Hospital, and we are concerned if we don't look to secure a future that we won't be meeting our national standards or specifications. The vascular case has been in the making for almost a decade now, so this is not just a quick decision, and it's about the right outcomes for our patients who have those specialist procedures. And I think we need to, again, this has been a clinically driven programme. This has, been considered by the National Getting It Right First programme team, and we've engaged with the Vascular Society. So this is about securing a single site for vascular service for the future to improve patient outcomes and to make sure we're compliant with standards and delivering the best care we can.
Thank you. Any questions, Silas?
Yeah, just to add to Craig's comments, whilst we talk about a single site, when we talk about a single site, we're talking about the most complex procedures, again, where you're requiring usually intervention from multiple clinical teams to get it right for patients. We are really clear, though, that for outpatients and ongoing rehabilitation, that will be done locally. We wouldn't be expecting patients to travel, because we think that's sort of not the right model for lots of reasons that I think are very obvious for people. In addition to the service that we provide to residents in Lancashire and South Cumbria, we also provide a service to residents in Wigan. I know Wigan have been involved in that, but we just sort of asking we just make sure that we keep colleagues in Wigan and the population in Wigan up to date with these changes as well, just as a note there, really. And then the final sort of driver for all of this as well is to sort of further sustain the improvements that we'll be making at the major trauma centre. So having all these more complex services located there supports us around our work that we do around major trauma, also the very complex gynecological procedures where there's a very high risk of patients bleeding out, and we need to make sure that we've got the right vascular team in place 24/7 to keep our patients safe and make sure they have a good outcome. Thank you.
Thank you. I find this a really interesting case, actually. I learnt a lot about vascular surgery. It reminds me of the programme that went ahead a decade or more ago around cardiac centres, about the centralisation of cardiac services. There is for very complex surgeries and for very complex, including actually ICU, complex ICU, there is a benefit in having a certain number of operations undertaken by experts, and that came through really clearly for me in the case. I can see a hand. Roy.
Thank you. Craig, yeah, just to agree with you about how long this has taken, and I'm so glad that we're coming to a conclusion on it, because I worked on a working group on this with Dr. Jim Gardner, who was a medical director about more than 10 years ago, in fact, and there was some huge discussions and debate about where this should be actually put. So we couldn't come to a conclusion on that, but that debate has continued. There's just one question I would ask, Craig. There's some papers mentioned in the paper about going to the HOS, the Health Overview Scrutiny Committees, from about 2018, but they've been updated since, clearly, on the progress on this. So have those papers been updated, and has that information been updated as well? Clearly it has, but it was a long time ago, so
yeah,
I'm happy that it's coming to a conclusion.
Yeah, so everything has got an updated position that's gone to the Health Scrutiny Committees with the most up-to-date position now. So we just wanted to reference what this is the journey that we've been on and the progress that we've made, because there has been more substantial progress, especially in the last 12 months.
Good. I'm not seeing any other hands. Are we happy to support this case to go to the next stage?
Yes.
We are. Good. Thank you all very much indeed. Right. Sorry, thank you. I thought I'd switched it on. I'd obviously switched it off. I think we're now coming to the next section, aren't we? Yes, governance and assurance. And the first is constitution and board membership, which Deb's going to take through. But again, there's just a couple of thoughts I thought I'd say in advance. And both of these papers set out some changes to the board and committee membership, which is designed to improve the assurance provided by committees and streamline the effectiveness of the board. And without wanting in any way to prejudice the conversation we're about to have, I did want to put on my record my thanks to the following people for their commitment and contributions as regular participants at the board. Sakthi Karamanithi, Kath Wally, Tracy Hopkins, David Blacklock and Victoria Gent, and also those who've contributed through the committees of the board. I know that we'll still be working with you, so in one form or another, so it's au revoir, not farewell, but I just think some people will as a result of this conversation, if it's approved, not be around the board table, and I do really very much appreciate the contributions that they have all made. Thank you.
Thank you, Chair. So the first paper, Constitution and Board Membership. So this paper presents changes to our constitution, specifically updates to board membership. It's been submitted to NHS England, which is in line with national guidance, and it's been formally approved by NHS England in February 2026. As part of the RCB's transition to the new operating model, a review of board composition has been completed to ensure that the skills, portfolios and accountabilities reflected at board level remain aligned to our statutory functions, strategic objectives and our maturing commissioning arrangements. So the RCB board currently consists of 15 members, supported by a number of regular participants, as Emma has just made reference to. And the changes that are proposed are aimed to strengthen shared accountability across the full executive team, further strengthen sector contribution and enhance board decision making. In terms of the executive membership, at present the board has 3 executive members in addition to the chief executive, who are the chief finance officer, medical director and chief nurse. In line with the updated operating model, executive portfolios have been reviewed and realigned to create clearer accountabilities tied to the delivery of the RCB's vision and medium-term plan. So from 1st of April, the board will have 5 executive members, with the addition of a chief commissioning officer and a chief strategy and planning officer. These changes also ensure that all executive roles form part of the unitary board as an equal member and reinforcing that shared accountability. As Aaron stated earlier, the RCB will still look to move to a single chief clinical officer, but until that time, the chief nurse and chief medical director roles remain in place, and we maintain that really strong clinical leadership as we have now. In terms of the partner members, the board currently includes 4 partner members. 3 of those are required in legislation, and we have an additional partner member who is our partner member for mental health. So the revised board proposes that we include an additional local authority member alongside the existing partner member, and a partner member for voluntary community, faith and social enterprise, VCFSE sector. A nominations and appointment process is currently underway for both of those new partner members, and we're expected that that they will assume their roles from April 2026. So those changes then mean that we will have a board membership of 19 members. And in developing these proposals, we've undertook engagement with and consultation with the incumbent executive directors and discussions with partners and stakeholders across the system. The full constitution is attached with track changes as an appendix because there are other areas that have clearly been updated, such as quoracy, within the actual constitution. And I'm happy to take any questions.
Thank you, Deb, and thank you for your work on this. Any questions for board members? Are we happy to approve that? Thank you. Thanks very much indeed. So we now move to the next item, which is governance and committee review. Still with you, Deb.
Thank you, Chair. So this item presents the outcome of a full review of the board's committee structure and associated governance documents. Again, this aligns to, I think we've heard a lot in the discussions today, aligning now to the publication of several national frameworks, model ICB blueprint, strategic commissioning framework, and the new planning, the NHS planning framework. So the purpose of the review has been to ensure that our governance arrangements remain aligned to these national developments and are fit for purpose as we transition into that new operating model, and aligned to what we've just discussed around our board and executive portfolios. So the review has been informed by a mapping exercise against core requirements that are in the strategic commissioning framework, a wider review of committee membership, chairing, frequency and meeting arrangements, and some of those arrangements are supporting, again, what's been touched on earlier about that, we'll have less resource and we need to be more streamlined and focused in how we arrange ourselves. And there's also been a light touch review of our Audit Committee and Remuneration Committee, again, just to maintain that consistency and that approach that we'll have as we're going to 26-27. So the key outcomes of the review are the most significant recommendation is the creation of a new commissioning committee, reflecting our responsibilities as we move into a strategic commissioner. Section 3 of the report sets out a high-level summary of the core areas of responsibility. So they include oversight of the annual integrated needs assessment, the annual refresh of the 5-year strategic commissioning plan that Craig has presented earlier, all prior to board approval, monitoring that progress against delivery of those plans and strategies, reviewing any proposals as we start to look at commissioning at scale and strategic commissioning partnerships, and ensuring that we've got that really meaningful involvement of residents, communities, stakeholders, and particularly in overseeing service change and making then recommendations to the board. Again, as we've seen today, but this committee would really provide that scrutiny and that assurance to the board prior than them coming for any decision or recommendations. The other committees, I won't go through all of the changes. They are in the paper and the terms of reference are all attached in full. They're again really just to reflect and align to the requirements of, so for example, the Finance and Contracting Committee, where we've now got different requirements around our medium-term plan, and that shift away from our role in that provider oversight as well. So from the rest of the committees, that's really where the focus has been on those changes. Very minor changes to the terms of reference of the Executive Committee. A number of other documents have been revised to reflect these changes, which includes our Scheme of Delegation and Reservation, our Functions and Decisions Map, and our Governance Handbook, all of which are statutory and are published on our website. There's no material changes within any of these proposals to delegated limits. and all of those again are tracked in the accompanying documentation. Just briefly on committee membership, membership has been refreshed, similar thinking to the board, so to reflect recent changes in executive portfolios and to ensure that we've got that consistent executive and non-executive representation through our committees. As we go into 26-27, we will undertake a review of the People and Culture Committee and the ICB's Transition Committee with the intention that they merge into a single committee from June 2026. But we'll bring that back to the board at that point so that the board can see what that looks like, and obviously there'll be a recommendation to approve that. So subject to approval today, the new committee structure will take effect from 1st of April 2026. The board assurance framework and risk management arrangements, again, will need refreshing and aligning. And there will be a full review of those in April 2026, and we'll see the outcome of that coming to the board in May. And I'll pause there. Thank you.
Thank you, Deb. So, I mean, governance should facilitate the good running of an organisation, and an organisation going through change will necessarily require tweaks, and in this case, some quite significant changes to governance. We will be keeping it under review, as we always will do, and we'll see. But I'm reasonably confident that it will help our processes. It will allow us to provide assurance or lack of assurance quite quickly to the board, which will support the way in which we take decisions. Any thoughts, comments, or happy to accept? Yes, Debbie.
Thanks, Chair, and thanks to Deborah for the work. There's a lot of detail, there's a lot of depth in terms of the work that you've done to build up and give us assurance around the approach. So no comments on the terms of reference. I think that they make absolute sense, and I really welcome the assurance mapping as well at the start of the document, because it helps us understand the different bits of the jigsaw, doesn't it, and how it builds up as an assurance map. It's a really obvious point, but there's some lines where there's a cross for every committee against a function. So it was just to say that as we start to look at how things run and fit together, if we're doing a review of how this framework works, that's probably one of the areas for sharpest focus, really, isn't it? Just to make sure that the chairs and the members of the committee are absolutely clear how that line is different in those different committees for the focus. But other than that, I do support it, and thanks for such a logical but also detailed approach that you've taken and then built back up for us.
Sort of reflection more than anything else, reflecting back on discussions around the BAF earlier this year, there was an element of confusion about ICB's system and what it is that we were trying to construct. I think the one thing this piece of work facilitates is a clear triangulation between the governance, the BAF, and then hopefully the work of the strategic oversight committees, because the committees should be focused on those items of strategy tied into the BAF. So I think it's a great piece of work individually, but what it does to really sharpen those other documents shouldn't be underestimated.
That's a good point, Steve. Important. Good. Are we happy to accept that? Great. Thank you. And again, thank you again for Deb, because this is, as I say, a significant piece of work. Okay. We now have EPRR, Emergency Preparedness, Resilience and Response Core Standards. Craig.
Thank you, Chair. So, yes, I'm here in my accountable emergency officer role rather than my commissioning role, and this is to bring you an update, which is one of the annual requirements in relation to our emergency preparedness, resilience and response. I'm pleased to say that you will see from the report this year we are at 91%, which is substantial compliance. For those of you who've heard me do this now, this is the third time. Our first year we were non-compliant, so I think it is excellent to see the progress we have made. I'm also very pleased to see that all of our provider trusts have declared themselves as substantially compliant as well. So that again is a significant improvement. In 25-26 we have seen comprehensive action plans in place, and the duty to maintain those plans has seen significant improvement. The command and control in incidents, the EPRR on-call mechanisms and training exercises, and business continuity. Multi-agency training continues to be a focus, and we will be looking at the arrangements for our on-call staff as a part of our refreshed operating model. We're obviously continuing with our approach to continuous improvement and learning from incidents, and we do that on a Northwest footprint. Also, we are reviewing our business impact analysis of organisational change, and we have been doing a significant amount of work due to our staff exiting on our business continuity, so we've actually refreshed a significant number of functional business continuities in line with our standards. We don't yet have the formal arrangements of how we will be assessed for next year, but we're working on the basis it will be similar, and our target obviously is 100% full compliance. So I will pause there, and I'm happy to answer any questions on the paper itself.
Thank you, Craig. It is good to see the improvement from last year. That's good. Is this, let me remind myself, this is for approval? Yes, yes. Any questions? Yes, sorry, Silas.
Yeah, just to firstly sort of say thanks to Craig and his team for some of the support that they've given us over the last 12 months about getting us up to standard. At times it can feel perhaps a little bit dry, this subject, but it is really critical for obvious reasons. And fairly about a year or so ago, again, we were on critical incident on the back of the unfortunate events in Southport with the riots, and certainly with a number of our trusts were actually receiving casualties incurred by the police when they were policing that incident as well. So it is real, is live, and it is really important that we get these right. Thanks.
Thank you. Thank you. Are we happy to approve this, the action plan? Excellent, great. And then now we have Audit Committee, Escalation and Assurance Report from Steve.
Thank you, Chair. And there's no written report because the meeting was only held yesterday, so I will give you an oral update. There were 2 alerts that will be in the AAA report when it comes out. And if you thought the last paper was dry, you'll listen to this one. So the first alert related to 2 limited assurance reports that we got from the internal auditors, and the committee felt that any limited assurance report should be alerted to the board. One was in respect of financial governance, and it was felt that budget monitoring, forecasting, financial analysis and reporting should be improved. Key findings: significant delays in budgets being accepted by 2 major programme areas, and non-acceptance by the budget holder of the all-age continuing care budget, which is a principal financial challenge. I'll allow Mark was in the meeting yesterday, and he was able to present some mitigations, which I'm sure he'll be happy to do again today. The other limited assurance area was in business continuity and IT services continuity, and the review found there was a compromised system of internal control for business and IT service continuity as operated by the ICB. Now, in both cases, this reflects a point in time, which is in the past, and I know that in both areas we've made progress since. Asim, who was the responsible officer for the second limited assurance, was not in the meeting yesterday and is not here today, so we didn't have any immediate comment from management, but the auditors are happy that management have taken on board the recommendations and have a programme of work to implement them. I mean, this led to a wider issue, which relate, there's a bit of a build-up of actions required to deal with audit findings. And there's a question mark in our minds about the capacity of the new reduced organisation to deal with all of the audit challenges that are being presented. Because, you know, then our numbers are reducing, but the scope of the audits is not reducing. In fact, they'll probably increase. And you know, so Mark was talking earlier about AI and etc. We need to move to a situation where the audits are more or less fully automated, because there are fewer people to deal with the audit challenges, which will increase probably as we go on. So that's the first alert. The second, and I'm not stepping into the Finance Committee's territory, but the second relates to what you've heard about before from Steve and Mark, which is the implementation of the new ledger halfway through the year. There is the potential for this to delay the completion of our audit. The reason being that KPMG, our auditors, are dependent on a set of service audit reports on the systems, so on the old system, on the new system, and on the migration of data between the two systems. The timing of those audits should be completed very soon, but we have no information as to when those audits will be completed. And if they're not completed on time, then KPMG's audit of our numbers will be compromised. I think the risk is low, but I didn't want to turn up at our special board meeting to approve the accounts in June, and for you to hear that the audit hasn't been completed yet, and you'd say, well, why didn't the Audit Committee warn us of this? So be warned. And that's all I had to say.
Thanks, Steve. Mark, you want to come back on the
Yeah.
internal audit?
Thank you, Chair. Yeah, just 30 seconds, if I may, on the financial governance report. So clearly, you know, any limited assurance report is not great to see or read. You know, very disappointing in lots of ways, but recognise the recommendations that were put forward. I think, again, I just want to thank the team, really, because I think it's been a bit of a kick in the teeth for them, quite frankly, given all the work that they've done, and, you know, the ledger being one good example of our endeavours to try and do everything that's needed to be done, despite the challenges we have. That said, you know, we have got the report, we accept the recommendations. I think, just for context, there is one high risk recommendation which influences the limited, as opposed to, you know, several high risks. It does relate, as Steve alluded to budget setting process, acceptance of plan, etc. And again, I think we've trailed that very much so during the course of previous board meetings in terms of what drove that position. I would suggest we've learnt the lessons from that, in terms of, you know, already this year, certainly since I started in September, lots of positive feedback on development of reporting, the processes we've undertaken for planning and budget setting for this year. Whilst they are, you know, not perfect by any means, we've got a much better framework around setting of budgets and alignment of WRP plans, to the point where, as you've seen, you know, pretty much 98% of them is now updated with PIDs, etc. So we're in a much better position. There are a number of other recommendations which, again, with the team are already working through and embedding. So I don't foresee it being a continuation into the 26-7 year. Keen always to learn those lessons and build on those recommendations. It's just yet a bit sort of disappointing in terms of the framing of it, but we'll move on and we will make sure we move forwards on that basis. Thank you, Chair.
Thank you. Any questions? I mean, this will come formally in any case through the written report, won't it, next time? So thank you. Thanks very much. Yes, Steve.
Just add, the internal auditors haven't finished their work for the year yet. We did try and get out of them what the overall assessment would be, and they're unwilling to write it down in blood. But I got the impression, and Debbie and Roy may, because they were there, and Mark, they may agree or disagree. I got the impression that we'll have a moderate assurance report overall on the year, which will be, you know, so the limited assurances will not affect the overall moderate assurance.
Let's hope that's right. Excellent. Okay, thank you. Now we have North West Specialised Joint Committee Escalation Report.
Thank you, Chair. It's a very short report. There are 3 alerts, advise and assure. There is an issue with timing, so this is obviously the January report. We've just had a Specialised Commissioning Committee last week. That report won't be ready until next week, which means it will then come to our May board. So I probably, outside of the board, just need to think about how we try and align these a little better, because there's a lot of progress on these. But I'm happy to answer any comments or questions. There's an update on the neonatal service review as well. But I just want to mention as well, I'm pleased to say you will have seen thrombectomy as an alert on every one all year, and it's now not an alert or advise or assure, which I'm pleased to report. So we want to see that continue. But I will work with Deborah outside just to look at alignment, especially as we've got a new committee. I think we can utilise our Strategic Commissioning Committee in relation to some of this AAA reporting. Thank you, Chair.
Thank you. Thanks very much. Any questions for Craig? No? Okay. The report concerning matters considered in private board meetings. Deb?
Thank you. I'll take the report as read. The board has met on 4 occasions over the period, and hopefully you'll see from the report that it's been very much for the purposes of meeting national timescales and what we've had to deliver around medium-term plan and model ICB requirements.
And I would just like to thank the board for being as flexible as they have, because some of these meetings have been at quite short notice in order to accommodate said timelines, but it is important that we've done that. Good. Okay, fine. And finally, any other business? Does anybody have any other business? No, nothing's been raised with me. Fine. Items for the risk register. I'm just thinking through. I'm not sure there's anything being raised that's not already captured, is there? Aaron?
Only to recognise, as we finalise the medium-term plan, we'll have a risk workshop with the board in April to update the BAF and the formal kind of risk construct. So more the plan risks that we've had discussions around today will feature in the board risk workshop.
Yeah. Thank you. Thank you very much. Great. So thank you. Quite a strategic. So from last time was quite operational. Today was quite strategic. That feels much better. That is where we should be. So thank you for your contributions, and look forward to the next